Hello.
Hi, is that Jacob?
It's Jacob. Hey.
Hi. We're just starting with the welcome slides, and then I will introduce you. So I'll just be about 5 minutes doing the welcome slides. Okay.
No worries. Yeah.
All right. So welcome everyone to the 16th Annual Transfusion Medicine Education Symposium. This year we have departed from using the Ontario Telemedicine Network for the first time in favor of streaming using GoToWebinar as our platform. So hopefully it will work for you. It seemed to work well this morning for us. So my name is Wendy Owens, and I am the program manager at the Ontario Regional Blood Coordinating Network, or ORBCoN, and I will be your moderator for the first half of this afternoon's event. I'd like to also give a special welcome to any medical laboratory technologists, colleagues out there. I wish you a very happy National Medical Laboratory Week, and just say how much we appreciate everything that you do and all the hard work that you put in, especially during this time. So the theme of this year's event is Game, Set, and Match, making transfusion decisions for patients that may present challenges both in the laboratory and clinical setting. Here's the agenda we have for this afternoon. We'll do our best to try and stick to these times. And we'd like to acknowledge and thank all of our contributors who make this event possible. Please note that this webcast will be recorded, and by participating, you are indicating your consent. The overall learning objectives of this educational event are listed here on this slide. So through attending this event, you should be able to identify patients who are at higher risk of alloimmunization, explain laboratory challenges related to serological testing of patients with a higher risk of alloimmunization, describe the clinically appropriate transfusion practice to minimize complications for these patients, and also to discuss any alternatives to transfusion for these patients. Just a reminder to all of you who are attending as part of a group to please respect and follow your organization's requirements for safety and COVID-19 precautions. We are very happy to announce that this event has received approval through the University of Ottawa as an accredited event by both the Royal College of Physicians and Surgeons of Canada and the College of Family Physicians of Canada. In order to claim your CME credits, you'll need proof of attendance. If you're attending at a site that is webcasting as a group, attendance sign-in sheets will be available from your site moderator. I just was told that I seem to be showing the wrong view of my slides.
You just need to minimize your control panel. Click on the orange button on your control panel.
Oh, got that. Okay, I'm sorry about that, everybody. Thanks, Tracy, for letting me know. Okay, so in order to claim your CME credits, you'll need proof of attendance. So if you're attending at a site that is webcasting as a group, the attendance sign-in sheets will be available from your site moderator. So any site moderators out there, please identify yourself to all your attendees and ensure that they sign in. And attendees, when you're signing the sheet, please make sure that your name and email address are legible. We'll use the email address to send you the evaluation survey and your attendance certificate, so it's important that we can read it. If you're attending by webcast, you'll have been asked to record your attendance when you logged in, and if not, then please contact Tracy Cameron. This year, once again, we're providing the opportunity for all attendees' names to go in a draw for prizes. 3 prizes are available this year. There'll be gift cards, 1 for Amazon, 1 for Indigo, and 1 for Esso. And the draw will take place at the end of May, and the announcement of the winners will be posted, as long as they agree, on the ORBCoN website. So please ensure your attendance forms are submitted to us no later than May 15th. We'll be posting the link to the evaluation survey in the chat function of the GoToWebinar, so you'll notice that Tracy will post it probably later on in the session. We'll also tweet it out if you follow us at ORBCoN1 on Twitter, and we'll also provide the link to you by an email following the event. We ask you to complete this evaluation as it provides valuable information for us to help us improve the seminar each year. And here's a copy of the certificate of attendance that you'll receive. And our speakers will be available at the end of the session after all the talks for a question and answer panel period. Please use the question function to enter your question. And you can also submit your questions via email to Tracy Cameron if you prefer that. We'll try and read out as many of the questions as we can for each of our speakers to answer. If we don't have time to answer all the questions during the question panel session, then we will be emailing the questions to our speakers and ask them to respond via email, and we'll try to get the response back to you. The GoToWebinar menu bar has a question function, so I was just referring to that. So all you have to do is select this, enter your question, and hit send. And if you can please let us know which speaker that you'd like your question addressed to, that would help as well. If there's time, we will also have some questions for you during the question panel part of the event. You'll be able to answer using a polling app. So if you, sorry, jump the slide. If you can just text to 37607, text the message ORBCoN CBS 685, and you'll join the polling app. These are the disclosure statements for the organizers, and we have no conflict of interest to disclose. So now we'll get started with our first speaker, who I will introduce to you. And in the meantime, too, we can pass control of the screen over to Dr. Pendergrass while I do his introduction. So Dr. Jacob Pendergrass, our first speaker for the afternoon, graduated in 1999 from Dalhousie Medical School in Halifax, Nova Scotia, and completed his training in internal medicine, hematology, and transfusion medicine at the University of Toronto before taking a staff appointment at the University Health Network, where he serves as an associate medical director of the blood transfusion service. He also works as a clinical hematologist and has been treating patients with hemoglobinopathies in the Toronto General Hospital's red blood cell disorders program since 2004. At the University of Toronto, he is ranked as assistant professor in the Department of Laboratory Medicine and Pathobiology, with a cross-appointment in the Department of Medicine. Dr. Pendergrass is a founding member of the Quest Research Collaborative, and his research interests include education in serology and adverse transfusion reactions, particularly IVIG-associated hemolysis and transfusion-associated circulatory overload. So please join me in welcoming Dr. Pendergrass. Dr. Pendergrass, are you there?
Hi there, I am here. I'm sorry, that was me on mute. Okay, you can see my slides okay?
Yes, we can see them fine, thanks.
All right, very good. All right, so again, thank you so much, Wendy and Tracy and Julia and everyone who was involved in organizing this event. It's a great honor to be invited, and I'm very happy to speak to you all about transfusion support for sickle cell disease. So I have no relevant disclosures for this presentation. I'm just going to go over the principles of red cell transfusion in sickle cell disease, which I think are important in terms of understanding both why and how to transfuse these patients. We'll define some of the accepted indications for red cell transfusion in sickle cell disease, certainly not all of them, but the more commonly encountered ones. And then we're going to spend some time talking about specifically hyperhemolysis, how to recognize it, how to prevent it, and briefly some options of treating it. So before we begin, it's worth reviewing quickly what sickle cell disease is. So this is a congenital disorder of hemoglobin, and it is the result of a single amino acid chain in the 6th codon position of the beta globin gene, which results in the replacement of a hydrophilic with a hydrophobic amino acid. And that makes all the difference, because that one hydrophobic domain means that when deoxygenated, the sickle hemoglobin crystallizes. And it crystallizes in a particular shape. It makes these long cable-like polymers, almost like needles. And they serve to stretch out the red blood cell, touching on the membrane, damaging it, leading it to become leaky so that the cell becomes dehydrated, dense. The membrane itself becomes rigid and brittle. And it also becomes activated so that it becomes more adherent to the endothelium, as well as serving as a nidus for thrombin generation. And from these properties, you get the two cardinal features of sickle cell disease, which is hemolytic anemia and vasoocclusion, particularly of small blood vessels, and with the secondary downstream effects of blood vessel injury. So the severity of sickle cell disease is influenced by many, many different things. And I won't go to all of them, but certainly one of the most important is what proportion of your total hemoglobin is sickle hemoglobin. And certainly if you have somebody with sickle trait who has only 20 to 30% hemoglobin S, these patients are almost totally asymptomatic and don't really require any special management at all in the medical setting. This is actually a fairly common finding is patients who are sickle trait. But as you go up to 50% hemoglobin S, which is what you get with hemoglobin SC, 70 to 85% with S beta plus, or almost all of your hemoglobin being sickle hemoglobin if you have homozygous hemoglobin S sickle cell disease, or a combination of hemoglobin S and total absence of beta globin production by your other chromosome 11, you get more and more severe disease. And that means that these patients are more likely to present to hospital, more likely to have complications, and unfortunately more likely to die young. Sickle cell disease is actually the most common genetic disease in the world. I think a lot of people are often surprised to hear this, but fully 5% of the human race carries the hemoglobin S mutation. It's extremely common. It evolved in response to evolutionary pressure from falciparum malaria, because being a sickle trait carrier provides you some protection from falciparum malaria. And it's estimated that in the endemic parts of the world where malaria is still active, there are still maybe 300,000 to 400,000 babies born every year with sickle cell disease. And even though in many parts of the world where there are not adequate healthcare resources, a good proportion of these babies die before the age of 5, there are at this point estimated to be 25 million patients with sickle cell disease in the world. And increasingly, we are seeing this in regions of the world that do not have exposure to falciparum malaria. And this is a result predominantly of immigration. And this is a slide showing the change in people migrating from regions of the world where sickle cell disease is common to, as in this example, the United States, although it would certainly be very similar if you looked at Canada. You can see there's been a 6-fold increase in the number of patients or individuals carrying this gene moving into North America and Canada in particular. And once they're here, we can then provide them the very basic and low-cost medical care, which results in significant improvements in life expectancy. So you can see, looking at this change in life expectancy since sickle cell disease was first recognized in North America in 1909, that simply paying attention to the fact that these patients exist was followed by an increase in life expectancy. Prophylactic penicillin, a further dramatic increase. Hydroxyurea, which is a off-patent, generic medication now, further increases. And then transfusion, which we'll be talking about today, resulting in further increases in life expectancy as well. So, for example, in the United States, and we don't have data in Canada, but I'm sure it's very similar, In 1971, the average life expectancy of a child with sickle cell disease was 17 years old. Now, patients are living into their 60s and beyond, so long as they are provided with good quality medical care. And as a result of these two phenomena, of the increasing prevalence of the gene in our population and the increasing life expectancy of patients with sickle cell disease, there are more and more of these patients that we encounter in our medical system. So we audited the number of sickle cell patients in Ontario a few years ago, and we found that there's probably about 3,500 patients just in Ontario. Over a 10-year period that we did this audit, the median hospitalization rate was 1 per patient, and the number of emerge visits was 2. And I think this is often surprising to people who feel that they see these patients very, very frequently in the emergency room or in the hospitals, but that's because you're seeing the sickest of the sick. Many of these patients are managing themselves at home or with outpatient care. And when you look at where they are really spread out throughout Ontario. Certainly, if you do this is a heat map of where the relative concentration of sickle cell patients are, they are much more commonly encountered in urban areas, particularly around Toronto and Ottawa. But they are present throughout Ontario. Every Lin region has a few sickle cell patients in them. And at some point, they will be presenting to the hospital, and there will be a decision that needs to be made about whether or not to transfuse them. And so that's what we're going to be talking about today, is how to judiciously and effectively use blood transfusions to treat these patients. Very often, this is how patients are encountered with sickle cell disease, particularly when they don't have good comprehensive care that keeps them out of the emergency room or out of the hospital. They will present in pain and seeking some sort of relief. And most of the time, you can manage these patients with good supportive care, but occasionally they will deteriorate to the point where their organs begin to shut down. And at this point, they may need transfusions, both to sort of rescue them from bad outcomes, but also to help long-term to prevent further bad outcomes. And the blood that we need to give these patients is difficult to source, and it can also be very injurious if you use it inappropriately. So it's very important to understand what the transfusions are actually doing when we give them to patients with sickle cell disease. And it's not exactly what we often assume transfusions are doing. Anytime you transfuse a patient, you are going to have to balance the two competing effects of adding red blood cells to somebody's circulation. The one effect that we think about the most is the increase in oxygen carrying capacity that you achieve with a transfusion. And that's a good thing. More oxygen carrying capacity means more oxygen delivery. But we are also impeding the perfusion of small blood vessels by increasing the hematocrit. And this in turn leads to worsened oxygen delivery. In more detail, you can consider the effect of transfusion on oxygen delivery from two competing perspectives. One is the macrocirculatory perspective, in which case the oxygen delivery is simply the cardiac output times the oxygen carrying capacity of the blood. In other words, rendered in this equation, where the oxygen carrying capacity is determined almost entirely by the hemoglobin. And so in this sense, higher hemoglobin means more oxygen delivery. That's why we transfuse. But from the microcirculatory perspective, we know that the flow of any fluid through a tube, i.e. blood through a blood vessel, is going to be inversely proportional to the viscosity of the fluid that's going through that blood vessel. And you can see that this effect is increasingly dominant the smaller the radius of the blood vessel. If you have a very small radius blood vessel, the viscosity effects become proportionally more significant. And because viscosity is in turn defined by the hematocrit, if you increase the hematocrit, you get lower flow, and therefore lower flow means lower oxygen delivery, i.e. the higher hemoglobin means less oxygen delivery. So these are these two competing effects of transfusion that we have to always be balancing between. Now, most of the time, we don't have to think about the microcirculatory perspective because most patients don't actually have that viscosity effect begin to dominate until the hemoglobin is over 150 grams per liter or so, or 15 grams per deciliter in this graphic. And we just never think to transfuse patients who have hemoglobins that high because that's already a normal hemoglobin. But with a sickle cell patient, the number is lower for that threshold. The number is more sort of a hemoglobin of 100 to 110, or a hematocrit of maybe 30 to 32%. And that's because patients with sickle cell disease have hyperviscous blood already. The blood is already more viscous than normal. And so the viscosity effects of transfusion are encountered earlier. So this is why you rarely want to transfuse a patient any higher than a hemoglobin of 100. But it gets even more complicated than that. And this stuff is important in terms of distinguishing the different situations when transfusion is helpful and not helpful. And this is a study where they looked at the effect of changing the hematocrit on the x-axis against the hematocrit to viscosity ratio. And they wanted to discover at what point does increasing the hematocrit lead to an even larger increase in viscosity. In other words, at what point does increasing the hemoglobin worsen oxygen delivery? And they found it really depended on a few things. First, it depended very much on the percentage of hemoglobin, which is hemoglobin S. And you can see if you have 100% hemoglobin S, and then you go to 25% hemoglobin S, at any particular hematocrit, your oxygen delivery will go up, okay? And that's whether you're looking at high shear or low shear. And shear is basically the effective pressure on a fluid to see how quickly the different layers of that fluid separate from one another. And if you have a high shear blood flow, you get the blood cells forming these nice laminar columns of blood where they flow very smoothly and without much interaction between them and the plasma proteins. But at low shear, the interactions become significant and the viscosity effects become even more pronounced. And so you can see that at low shear and high shear, the viscosity effects are very different. At high shear, increasing the hematocrit generally looks like it's a good thing. And at low shear, it looks like it's a bad thing. It looks like it worsens oxygen delivery. Now, these experiments were done with sickle blood that was oxygenated. When you deoxygenate blood from somebody with sickle cell disease, the viscosity increases by tenfold. And now you see a different effect. At low shear, again, increasing the hematocrit makes the oxygen delivery worse across a large range of hematocrits. But even at high shear, when it's deoxygenated, increasing the hematocrit at some points starts to become worse as well. And that point is, again, a hematocrit of around 30%. Going past that point, worsening your oxygen delivery. And this is true regardless of how much you have diluted the hemoglobin S with your transfused blood. Again, if you look at going up the y-axis as the good thing that you want to achieve, if this is sort of a surrogate marker for increasing oxygen delivery, you can see that you move up that axis most effectively by diluting your hemoglobin S down rather than increasing your hematocrit, okay? Very, very important finding in the study and very relevant to clinical practice. What this means is if you are dealing with a vascular bed that has low shear and low oxygen tension, for example, the post-capillary venules found in the bone marrow, which is where patients experiencing vaso-occlusive pain are having tissue necrosis, in those vascular beds, transfusing may actually worsen oxygen delivery, which would suggest that if you have a patient coming into your hospital having a standard pain crisis where they're having necrosis of their bone marrow and their long bones, their back, ribs or what have you, increasing their hematocrit by transfusion may actually prolong their pain crisis. It will not actually make it better. It may actually make it longer. In a high shear vascular bed, it's a different story. So this is more like brain, kidneys, and lungs. Here, this is sort of the target organ of a patient having a sickle cell disease crisis. Increasing the hematocrit may in fact help. That may in fact increase the oxygen delivery to that particular organ bed. However, it only has that effect up to a hematocrit of 30% or so, or hemoglobin of around 100. And then past that point, even those high shear vascular beds begin to have worsening oxygen delivery. Okay. Rules of thumb, therefore, when transfusing a patient with sickle cell disease. In most cases, the benefits of transfusing does not come from increasing the hemoglobin or increasing the hematocrit, even though that's what we're often paying attention to. What the actual benefit is due to is decreasing the hemoglobin S percentage. That's actually what we're trying to achieve when we're transfusing. We're trying to decrease the hemoglobin S percentage and overall decrease the blood viscosity. And if you are trying to transfuse a patient to get their hemoglobin S percentage down, there is only so much blood you can give that patient before you hit that ceiling of a hemoglobin of 100 to 110 grams per liter. And past that point, you may make them worse again. And this is why exchange transfusions are often necessary in patients with sickle cell disease, where you take the blood out first and then transfuse. It's to get that hemoglobin S percentage down low without increasing your total hemoglobin. Exchange transfusion is so central to the care of patients with sickle cell disease that it's actually a standards requirement in many countries that any hospital that is likely to encounter a patient with sickle cell disease, which in Ontario pretty much means every hospital, must have the ability to do at least a manual exchange transfusion. And larger referral centers where there is more comprehensive care provided should be able to do an apheresis exchange. And that's a relatively small number of hospitals in Ontario. That includes UHN, Mount Sinai, the Hospital for Sick Children at St. Michael's Hospital in Toronto, London Health Sciences Centre, and the Ottawa Hospital. Everywhere else, you're going to rely on manual exchange transfusion, at least to buy you time until you can get your patient transferred out for an apheresis exchange, if that's in fact what they're going to require. A manual exchange transfusion protocol is not complicated. This is a typical protocol for an adult where you phlebotomize the unit, infuse 500 cc's of saline, phlebotomize the second unit, and then transfuse 2 units. There are various modifications to this, but it's fairly straightforward. Anyone could do it, and it can really be life-saving. And pretty much every hospital that has sickle patients in its catchment area should be able to offer this to them. The automated apheresis exchanges are faster, they're more precise, but they do require more blood, specialized equipment, specialized people to run that specialized equipment. So it's important to kind of know where in Ontario your nearest apheresis site is, should your patient require transfer to that hospital to get that level of care. Okay. Now, we are very used to transfusing patients to treat their anemia. That's actually why we transfuse almost all of the time. And sickle cell patients are anemic at baseline. So the question is there a point at which the anemia itself becomes an indication to transfuse patients? Is it always about the hemoglobin S percentage? Or is there ever a point when the patient is so anemic, we just actually need to increase their oxygen carrying capacity? And the answer is yes, but it's at a much lower threshold than many people would expect. And you have to remember that the baseline hemoglobin of a patient with sickle cell disease is probably between 70 and 100 grams per liter already. That's their baseline. So they have to fall significantly below that before they become at risk of impaired oxygen consumption. And that threshold, for the most part, is a hemoglobin of 50. Now, that's a very low number, and people are often not comfortable letting a patient get that anemic before they transfuse. And certainly there are situations where you might need to transfuse at a higher hemoglobin if the patient's hemoglobin is falling very, very rapidly, or if they are having significant symptoms of their anemia. Although you have to be careful not to ascribe every symptom a sickle cell patient is having to their anemia. There's many reasons a patient might be fatigued or dyspneic, for example, that have nothing to do with what their hemoglobin is. But below 50, most experts would say, even if you're not symptomatic, you should think about transfusing prophylactically. But then you have to ask, what would drive a patient's hemoglobin to less than 50 with sickle cell disease, besides hemorrhaging, for example? And there are three main causes for a hemoglobin to fall that low. And they have to all be considered as distinct entities that need their own distinct transfusion practices. And these are an aplastic crisis, a sequestration crisis, or hyperhemolysis. An aplastic crisis is generally due to infection with parvovirus. I should mention you can get an aplastic crisis by accidentally taking too much hydroxyurea, but hopefully that doesn't happen if you're monitoring your patient carefully. But not much you can do to prevent a parvovirus infection. In fact, 75% of patients will have, with sickle cell disease will have developed parvovirus immunity by the time they're 20 years old. It's a classic pediatric exanthem. And with sickle cell patients, as with all patients, parvovirus temporarily shuts down your reticulocyte production. Most of us can take a week having no retics because our existing red blood cells last long enough to carry us through. But a sickle cell patient whose red blood cells are much shorter lived will drop their hemoglobin fairly quickly, like up to 30 grams per liter. And that may get them down below that threshold of 50. And that might be a time that you need to transfuse that patient. However, that fall in hemoglobin does not occur the way it would in a patient who is hemorrhaging, i.e. these patients are euvolemic by the time they present. And so it's very important if a patient walks into the emergency and says, I don't feel so good, and you do a CBC and you see their hemoglobin is 40, for example, not to panic and transfuse them 3 or 4 units of blood back to back. These patients are prone to volume overload, particularly if they have a history of pulmonary hypertension, which is often seen in the setting of severe anemia. So transfusing 1 unit at a time and then carefully reassessing their volume status, rechecking their CBC, is the order of the day with an aplastic crisis. And that's pretty much all you need to do. Maybe, 1 unit, maybe 2, and then they will clear the parvovirus on their own, and unless they're immunocompromised, and their hemoglobin will come up with their reticulocyte count, and then that's it. That typically this only happens once. Sequestration crises are very different. This is due to trapping of red cells in the splenic sinusoids. This can also occur in the liver, and you'll see that more often in adults. It's not as severe because the liver is not as distensible as the spleen. But the spleen, before it has infarcted away in the prepubescent years in patients with sickle cell disease, is prone to massive and very rapid expansion as it starts trapping more and more blood within it, to the point where these patients can actually go into shock and die. And this, in fact, was historically a common cause of death for patients with sickle cell disease, the sequestration crisis. And then once it happens, unlike an aplastic crisis, it happens increasingly frequently moving forward. You don't develop immunity to sequestration, you actually develop predisposition towards it. And so you need to actually take the spleen out often to keep this from happening again. But just to get to the splenectomy, you may need to transfuse these patients to stabilize them. And so the transfusion can be life-saving in this situation. However, the consideration you have to always be aware of with sequestration crises is that the blood that has been sequestered in the spleen, and this can occur in the liver as well, is often still viable. It's just trapped. And then as you transfuse and increase oxygen delivery to those trapped red blood cells, the hemoglobin comes out of its crystallized form, the red blood cell relaxes, it escapes from the circulation, and you get this phenomenon of auto-transfusion. And what this manifests as is an unexpectedly large increase in your hemoglobin from your transfusion. The hemoglobin goes up higher than you would have expected it to. And this can actually lead to polycythemia if you transfuse too aggressively, to the point where many pediatric centers will only transfuse a sequestration crisis, because again, this is mostly seen in infants or young children, will only transfuse them half of a standard dose of red blood cells, knowing that the difference will be made up with the blood that was sequestered in their spleen. So often just a single transfusion episode, sometimes even just at low volume is all you need to recover from this, and then you can get your patient to splenectomy. Finally, there's hyperhemolysis. So whereas a sequestration crisis leads to a higher increase in hemoglobin than you'd expect, hyperhemolysis leads to no increase or even a decrease in your hemoglobin. The transfusion makes your patient more anemic, and you can see that this is happening due to rapid clearance of the transfused blood. If you do a hemoglobin electrophoresis, the hemoglobin A proportion rapidly disappears. And it's disappearing along with the patient's own red blood cells in this storm of hemolysis. Now, typically, if this shows up, maybe 7 days or more after transfusion, you will see a new antibody. You will see a new antibody in the plasma of that patient, and you'll be able to determine this looks like some sort of extreme form of delayed hemolytic transfusion reaction. But there is another form that shows up even sooner than that, where you don't see a new antibody. And the typical progression often is that a patient who is transfused first develops this delayed onset hyperhemolysis, and then as they get transfused again, and the hemolysis starts to accelerate, you see even more hemolysis even sooner without any new antibodies. And there's something going on, it looks like, where what started out as a delayed hemolytic transfusion reaction goes out of control and leads to rapid destruction of all blood, the patient's blood, anything you transfuse, everything. This is an example of a patient we had who we unfortunately lost to hyperhemolysis. And she was transfused and had a good increment at first. And then her hemoglobin began to drop very rapidly. And this looked like it was due to an anti-N, which is not an antibody that we typically pay a lot of attention to. It's usually considered as kind of a nuisance cold agglutinin, but there are increasing reports of M and N antibodies causing severe hemolytic transfusion reactions in sickle cell disease, and this was one of them, unfortunately. And you can see her LDH skyrocketed. Her bilirubin didn't have a chance even to go up by processing all the liberated hemoglobin. Her reticulocyte count began to bottom out, and we lost her. We tried treating her with IVIG, steroids, rituximab, erythropoietin, continued the hydroxyurea, nothing. Her hemoglobin fell to almost 20, and she passed away. Again, absolutely tragic, and the kind of transfusion reaction you want very much to avoid in patients with sickle cell disease, who are almost the only patient population you will see this in. There are examples in other disease states as well, but it's really mostly seen in sickle cell disease. In terms of what is going on, it's more than simply the typical pattern of a delayed hemolytic transfusion reaction, although that's often how it starts. You have a patient who has made an antibody in the past. We didn't know about it because it has fallen in titer below the levels of detection. And then when they are re-challenged, they have an anamnestic response, more antibodies, higher titer, higher avidity, and lysis of red cells ensues. That's how it begins. But then something else happens. And we don't know exactly what that something else is. It does appear to involve macrophages to a certain extent. We can see the ferritins get very, very high, like a macrophage activation syndrome, and there are a variety of other ligand binding mechanisms by which a macrophage can phagocytose a red blood cell, even if it's not covered in antibodies. So macrophage activation looks like it's part of this. More recently, there's evidence that widespread complement activation is also important, and that it may be that is also fueling the fire. But we just actually don't know. We don't really know what is going on with hyperhemolysis. The key thing is that once you see that it is happening, you must stop transfusing, because the transfusion only seems to be adding fuel to the fire. And instead, you need to start immunosuppressive therapy. First-line therapy is IVIG and steroids. You can add some erythropoietin if the retic count has fallen to less than 250, which is where it would need to be, at least, in order to compensate for the degree of anemia. And if the patient is starting to develop end organ disease, i.e. if they are going into renal failure, or if they are developing an acute chest syndrome, or becoming increasingly cognitively impacted by their anemia, then increasingly people are saying you need to reach for eculizumab and or rituximab in order to further shut down the immune system. And if you can do these things, stop transfusing, treat them with these potent immunosuppressive therapies, put them on high flow oxygen, just to maximize the plasma oxygen delivery, you can get these patients through this and they will recover. But once this has happened, this is considered a contraindication to ever being transfused again. And patients need to be told this, and other blood banks need to be aware of this. That a patient who develops hyperhemolysis, everybody needs to know that patient is essentially a Jehovah's Witness now. They should only be transfused under absolute extreme circumstances. They need to be aware of the risk. They need to be pre-medicated with potent immunosuppressive therapies. So again, something you definitely want to avoid setting off. Okay. Most of the time, however, we are not transfusing patients because their hemoglobin is less than 50. And in other words, our goal of transfusion is actually to decrease the hemoglobin S percentage. In other words, the goal of transfusion is to decrease the blood viscosity. So what are we trying to do exactly? What are our endpoints in this situation? So again, we want to get the hemoglobin S percentage down, typically to less than 30%. That's considered to be effective at suppressing most of the pathological effects of sickle cell disease, while keeping the total hemoglobin less than 110. The evidence supporting that practice, or evaluating it at least, is pretty much limited to pregnancy, perioperative management, and stroke prevention. We use the same approach of trying to get the hemoglobin S percentage down to less than 30% for acute chest syndrome and Cyclohepatopathy, and there are some other rare complications as well, but those two are considered pretty much standard of care, so we'll talk a little bit about them. Okay, so decreasing the whole blood viscosity for prophylactic purposes, pregnancy. It doesn't look like, based on the available evidence, that keeping the hemoglobin S less than 30% will improve fetal outcomes. It doesn't lead to higher birth weights, doesn't lead to longer gestation, doesn't decrease miscarriages or stillbirths. And for that reason, it is not routinely recommended. Now, this is based on a very old study that people have criticized for starting transfusions too late. And maybe if they'd started earlier, the placenta would have developed more effectively, and then the baby would have benefited. But that's conjectural at this point. So unless there is something really very concerning about this particular pregnancy, for example, if it's a multiple pregnancy or they have kidney failure or other comorbidities, then we should only really be transfusing if we're expecting the mother to benefit, which actually does appear to work when you're transfusing a pregnant woman, to the point where some guidelines will say that if you have to take a patient off hydroxyurea for her pregnancy and she was really benefiting from it, then you might think about starting her in transfusion support just to benefit her, if not the fetus, developing fetus itself. Perioperative transfusion support. There are several studies here that partially answer the question of how to do this properly. This is, I think, sort of a reasonable summary of the evidence that we have, which is that for very low risk procedures in a relatively low risk patient, i.e., things involving cataracts or superficial biopsies or vaginal deliveries, you don't need to transfuse these patients. Just good supportive care is all you need. But everybody else should be transfused. And then the question about whether you should do a top-up transfusion, which is essentially getting your hemoglobin S down to 60%, or an exchange transfusion with the goal of getting to less than 30%, depends largely on how sick your patient is, how risky the procedure is, and what their baseline hemoglobin is. So a higher risk patient undergoing a higher risk surgery or having a high hemoglobin, i.e. greater than 90, you should refer for an exchange transfusion. Other patients, you could probably get away with a top-up. What about stroke prevention? Lots of randomized controlled trials in children with all sorts of fun acronyms like STOP and switch and sit and twitch and all these sorts of things. But the bottom line is that transfusion is first-line therapy for both primary and secondary stroke prevention. And with secondary stroke prevention, you have to keep that hemoglobin S less than 30% forever. At this point, we have not found an effective alternative to transfusion. For primary prophylaxis, i.e. patients who have high flow transcranial Dopplers, it does look like you can, in certain situations, transition that patient from transfusion to hydroxyurea and phlebotomy. The wild card scenario that we haven't really figured out yet is patients who have silent infarcts. So these are patients who have had MRI scans and they've had no history clinically of having had a stroke, but then you see evidence of strokes on the MRI. High rate of recurrence in this population. However, we cannot transfuse all of these patients indefinitely, certainly, because the prevalence is so high, there's just not enough blood. So there do appear to be some patients with silent infarcts who you can stabilize in hydroxyurea. Others you do need to transfuse. We don't know how to tell the difference quite yet, so it's a bit of a case-by-case assessment. In adults, we don't have any randomized controlled trials. We have a lot of adults who started on chronic transfusions for secondary stroke prophylaxis as children and have just continued. But if they've had their first stroke as an adult, the first question you have to ask is, was it due to the sickle cell disease or was it due to something else? Did they have atrial fibrillation with cardioembolism, for example? And if that's what it was, then you can just manage them for that condition, i.e. anticoagulating them, for example. But if it looks like it was due to the sickle cell disease, at this point, it looks like transfusion continues to be first-line therapy. The only caveat to this is that patients with sickle cell disease tend to have hemorrhagic strokes when they're adults. And it's generally considered not a good idea to do an exchange transfusion on a sickle patient who is actively bleeding. So you have to wait, I would recommend anyway, waiting for that intracranial bleeding to stop and then start transfusion with the goal of preventing the next stroke. Okay, what about transfusing for therapeutic purposes with the goal, again, to decrease your hemoglobin S percentage? Acute chest syndrome is considered a standard indication for transfusions in all but the most mild cases. And acute chest syndrome is just any new pulmonary infiltrate on chest x-ray accompanied by fever and or respiratory symptoms. That's an acute chest syndrome. It can be caused by many things. It can be caused by embolism of necrotic marrow in the setting of acute vaso-occlusive crisis. It can be caused by an infection, including COVID-19, unfortunately. Often we don't know what triggered it. But once it has started, you can get this spiraling vicious circle of hypoxia resulting in further sickling, resulting in further dead space within the lungs, resulting in further hypoxia, further sickling, et cetera, and you get this rapid whiting out of the lungs. And the mortality rate from this can be quite high. So this is considered, along with empiric antibiotics and good chest physio, to be a pretty strong indication for transfusion support, again, just based on observational studies. A question that hematologists get asked often is, when do you need to have an exchange transfusion arranged versus a top-up transfusion for an acute chest syndrome? And we don't really know. But the following indicators here of poor prognosis, physical exam findings, lab or radiology findings, to me, these are indications that a patient is probably not going to recover with just a top-up transfusion, even if that's what you need to start them on. And you will need to make arrangements for some sort of exchange transfusion, either a manual exchange or, in really severe cases, an apheresis exchange. And so if you see any of these things happening, then you should begin making arrangements for an exchange transfusion. Don't wait, because these patients can deteriorate very rapidly once an acute chest syndrome starts. And typically, this happens while they are hospitalized for a pain crisis. So you have to keep an eye on your patients while they're in hospital to make sure that this is not developing as a complication of what seemed at first to be just a simple pain crisis. Cyclohepatopathy. This presents as severe right upper quadrant pain, hepatomegaly, coagulopathy, severe hyperbilirubinemia, liver enzymes only modestly elevated. In children, this can sometimes reverse just with supportive care. In adults, it tends to be more insidious and progressive and can actually result in complete liver failure and the need for a liver transplant. So if you see this developing, particularly in an adult, most would consider this to be a pretty good indication for transfusion support, and I would say an exchange transfusion. If you were to biopsy these patients, you would see ballooning of the hepatocytes, resulting in pinching off of their canalicular canals and intrahepatic cholestasis. But you should actually not biopsy these patients. It is dangerous. It's sometimes hard to tell exactly what's going on in the liver of a patient with sickle cell disease who has high bilirubin and high liver enzymes. But if it meets this clinical syndrome, as described in the first bullet point here, you can probably assume this is cyclohepatopathy, and transfusion is likely indicated. Okay, so lots of different scenarios where you might want to transfuse. It might not want to transfuse, and it's hard to keep it all in your mind when you're confronting a patient. For the most part, I think the takeaway message for most physicians is just knowing when you should not transfuse. And that would be patients who have compensated anemia or uncomplicated pain crisis, and everybody else, probably best just to get a hematology consultation because it is complicated in terms of determining when to transfuse, how to transfuse, and also, this would be what I end our talk on today, with what to transfuse. Because the patients with sickle cell disease are going to need very specialized blood product support. And we do know that if you just transfuse these patients the way you transfuse your other hospital patients, i.e. you've got an OPOS patient with no antibodies, you can just give them a unit of group OPOS. There is a very high likelihood that these patients will develop antibodies, typically antibodies against CE and KEL antigens. And that's largely due to differences in antigen expression between your typical blood donor and a patient with sickle cell disease. There's a high risk from this because once these patients have made these antibodies, they are at high risk of getting exposed to them a second time because very often these antibodies fall off and teeter by the time we see them again next, particularly if patients are going from hospital to hospital, which is unfortunately the level of care many adult patients with sickle cell disease are still left with. And if they get re-exposed to an antigen that they've made an antibody to, they can have a delayed hemolytic transfusion reaction. And as we talked about, that can lead to hyperhemolysis. And sometimes you won't even see the antibody that did it because it will be absorbed onto the blood that you transfused, and it will no longer be detectable as a screen. This is why we prophylactically match sickle cell patients for common antigens. One of the questions we face is how much prophylactic matching? This is a really tricky question to answer. You can see that the more extensively you match a patient for antigens that they could make an antibody to, there are diminishing yields in the number of antibodies that you prevent, but a dramatic impact on the available blood supply. So it looks like, according to this study, providing RH and KEL matching is going to prevent most of your antibodies in most patients without making the blood supply too difficult to source. You only go down to the more extensive matching for patients that you are particularly worried about. And the ones that we worry about are the patients who seem to make antibodies really robustly. And studies have shown that there does appear to be a population of around 13% of the general patient population who make most of the antibodies. These patients are responders, and they seem to make a transfusion, make an antibody, maybe every 1 of every 3 transfusions. So the question then is, how do we identify which sickle cell patients are antibody responders? And at this point, the standard of care is just, if they've made 1 antibody, they will probably make more. Now, one question is, does it matter what kind of antibody they made? Like if they make an antibody to something kind of clinically insignificant, like do we need to prophylactically match those patients as well? I would say yes. I would say that even if the first antibody they made was not clinically significant, they have nevertheless shown themselves to be somebody who responds to transfusion by making antibodies to foreign red cells, and I would not take any chances on that patient, and I would provide that patient with a fully matched blood. Something else I didn't mention this morning, which I think is worth emphasizing, we are increasingly seeing patients in Canada who had previous transfusions overseas. And there we have no idea what kind of prophylactic matching they might have received. The blood probably wasn't even leukoreduced. So the likelihood that they have made antibodies in the past that we can't see now is even higher. So those patients who have been transfused overseas somewhere and we don't have their history, I would do the same prophylactic matching, extensive matching. Do have to also consider the importance of partial antigens, which are very common in sickle cell patients, particularly the partial C antigen. This is due to a transposition of part of the C antigen into the RHD gene, rendering that patient RHD negative, but C positive by phenotyping, and yet still capable of making an anti-C if you transfuse some C positive blood. That scenario, the partial C, is to my mind the main reason that we need to genotype all of our sickle cell patients in order to find out which ones we need to prophylactically give C negative blood to, even if they phenotype as C positive. Importantly, even though we know that partial Cs are very common amongst Black patients, and most of our sickle patients are of Black ethnicity, it's also increasingly being appreciated that Black donors have a high expression of what we would normally consider to be low frequency antigens. And so you look here at things like VS or JSA or V or Gonzalez, there's a whole list of these. Antigens that we would normally consider to be very rare are actually relatively common in people of African ethnicity. And this is important because if you are then transfusing a sickle cell patient with blood from a Black blood donor, there's a pretty good chance you're going to expose them to one of these low frequency antigens, to say low in quotes. And if they make an antibody to those low frequency antigens, because our blood system is unfortunately still very oriented towards Caucasians, you may not see that antibody on typical screening cells. So they could make an anti-V and you would never know because your screening cells are not likely to express the V antigen. So this unfortunately gives us this conundrum where the more extensively we prophylactically match our sickle cell patients for things like C, E, Cal, Duffy A, JKB, and S, the more likely we are inadvertently asking for a Black blood donor. And that increases the likelihood that we're going to expose a patient to a low frequency antigen, and those antibodies we therefore may not see. So we may need to start further enhancing our degree of matching by also genotyping our blood donors. Even beyond that, we may need to start sourcing specialized typing, not typing, but screening cells or panel cells for our sickle cell patients so that we can pick up some of these lower frequency antibodies and not rely entirely on the cross match. And this may also in the future be an important way of preventing hyperhemolysis. There are other considerations that you'll find in older literature in transfusing a sickle cell patient saying that you should only be giving the patients from sickle deck negative donors, which basically means from donors who are not sickle cell trait. Probably not necessary from a medical perspective. Certainly sickle trait positive blood will confound your measurement of your patient's hemoglobin S percentage, but sickle trait blood is not itself dangerous. Fresh blood is often preferred. It lasts a little bit longer. But again, if all you have is old blood or frozen blood in order to meet your patient's antigen matching requirements, that's more important. So antigen typing is a more important consideration than it being from a sickle deck negative donor or from a fresh unit. So I will stop there. I'm not sure if we have time for questions right now, but if not, I'm happy to field questions during the panel discussion at the end of the afternoon.
Okay, well, thank you very much, Dr. Pendergrass. It was a wonderful presentation. And yes, I'm afraid we are behind a little bit on our agenda, so we won't take questions now. We'll wait until the question panel. If you can return at about, I guess, 3:30, that would be terrific. Thank you so much.
3:30 it is. Okay, thank you.
Thanks. Okay, now we'll move on to our second speaker, and I'll make her introduction as we're switching over to her screen. So our second speaker this afternoon is Dr. Yulia Lin. Dr. Lin is the Division Head of Transfusion Medicine and Tissue Bank at Sunnybrook Health Sciences Center and Associate Professor in the Department of Laboratory Medicine and Pathobiology at the University of Toronto. She is the Physician Lead for Transfusion for Choosing Wisely Canada, the Chair of the Ontario Transfusion Coordinators Network, or ONTRAC, Steering Committee, and a Program Investigator in the University of Toronto Quest Research Program. Her academic interests include physician education in transfusion medicine, quality improvement in patient blood management, and transfusion safety. Dr. Lin has also recently joined us as the sponsor for the Ontario Regional Blood Coordinating Network for the Central Ontario region. So please welcome Dr. Lin.
Thanks so much. Really excited to be here, and really excited to talk to you all about transfusion support for patients with myelodysplastic syndrome. So I have no disclosures to disclose. And I just wanted to start off by wishing everyone who's on the line a happy National Medical Laboratory Week. I have the opportunity to work with some amazing medical laboratory technologists, both here at Sunnybrook and across the province and country. And I just wanted to say thank you for everything that you do, and especially to our microbiology MLTs, thank you. I know it's been a really stressful time. So I wanted to start off with a case study of a new hematologist who comes to your hospital, and she has a 72-year-old male with myelodysplastic syndrome and severe anemia, and she thinks that she's going to have to start this patient on chronic transfusion. So she's come from another center, and so she calls up the blood bank and asks you, are there particular transfusion guidelines for outpatients here? And do you have any suggestions about blood bank testing or measures that I need to order to help my patient? So I hope by the end of the talk today, you'll be able to compare the approach to transfusion in patients with MDS with the approach to transfusion in hospitalized patients. I hope you'll think about the quality of life considerations for transfusion in patients with MDS. And finally, talk a bit about the discussion, about potential complications of transfusion in patients, the prevention of these complications and their management in these patients. So first, what is myelodysplastic syndrome? So MDS is a myeloid neoplasm that results from clonal proliferation. And so here on the slide on the right, we have the bone marrow with its hematopoietic stem cells and precursors. And over time, there are acquired mutations that result. And at some point, one of these mutations may actually lead to a survival advantage, resulting in further proliferation, and may actually impact as well on differentiation. And in these cases, when these clones are significant, they can result in MDS. So MDS is really just that, the abnormal formation of hematopoietic stem cells, and it results in ineffective hematopoiesis, cytopenia, so low blood counts in terms of the hemoglobin, the white blood cell count, as well as the platelet count, and a risk overall of evolution to acute leukemia. The incidence is about 4 to 5 per 100,000 persons per year, although this is likely an underestimate because you do need a bone marrow biopsy for the diagnosis. And the median age is about 70 years. And there's quite a spectrum. So in this range here, from just some clonal proliferation to leukemia, there's actually quite a spectrum. So there are lower risk patients who make up about 2/3 of the patients with MDS, and higher risk patients, about 1/3, who have a very high risk of progressing on to acute leukemia. So the issue with MDS and transfusion burden is quite significant. So MDS is the second leading indication for transfusion amongst hematologic diseases, and accounts for about 7.2% of those transfused patients. And at some point in the natural history of MDS, even with treatment, most patients will eventually become transfusion dependent. And so here's a study from Sweden that looked at over 2,000 patients in the first 4 years after diagnosis. And looking at the IPSS-R score, which is a prognostic score, those patients who had very low risk still required about 25 red cells in the first 4 years at a cost of about $8,800 US. And this was based on a red cell unit cost of $169 US, which is less than the current Canadian Blood Services published cost, which is around $425 Canadian. And this spectrum goes all the way to the high-risk MDS patients that actually require 171 red cells on average in the first 4 years and 66 platelets in that time frame, and that increases the cost by about tenfold to about $80,000. So quite an impact that MDS has on transfusion. As well, not only does MDS account for a lot of the transfusion burden, but transfusion in and of itself also has impact on patients with MDS. So transfusion dependence in MDS, so that is receiving more than 1 unit per month over the course of 8 weeks, is associated with worse outcomes, so decreased overall survival. So here on the right, you can see the blue line is red cell transfusion independent patients compared to transfusion dependent with months since diagnosis along the x-axis. There's also, interestingly, a risk of non-leukemic death. And so we're going to talk about that on the next slide, the reasons for why that might occur. And there's increased cost of illness in terms of medical costs, hospitalization, and ER visits, as well as an overall decrease in quality of life, affecting all of these domains in terms of physical, emotional, and social aspects of quality of life. So how does transfusion impact so adversely on MDS? So MDS in and of itself does have, due to its ineffective erythropoiesis, a issue in terms of iron overload. And so because of this iron toxicity, there can be direct effects on cardiac tissue, leading to cardiac events, impaired immunity in terms of our T cells and infection, as well as oxidative stress. And these can all promote genomic instability that leads to further clonal evolution and transformation to acute leukemia. Transfusion, of course, can also lead to iron overload directly, but also can create an inflammatory environment that further promotes this genomic instability. And finally, we can also see transfusion reactions directly from transfusion. So the question is, are there transfusion guidelines for outpatients with MDS? And unfortunately, the short answer here is no, at least not yet. So, when we look at systematic reviews of the randomized controlled trials that have been done in transfusion, they have all been done in the inpatient setting. And they do show a lot of consistency in terms of favoring a restrictive versus a liberal transfusion threshold when you think about and look at 30-day mortality as an outcome. This is reflected in the guidelines. So from AABB, looking at the usual transfusion thresholds that we're used to, so 70 for hemodynamically stable hospitalized patients, and then considering transfusion if the hemoglobin is less than 80 for orthopedic surgery, cardiac surgery, or patients with cardiovascular disease. But if you read the fine print, there are recommendations that suggest that these do not apply to patients with severe thrombocytopenia, such as the heme-onc patients, or patients that have chronic transfusion-dependent anemia. So we can look at some of the inpatient studies that have looked at hematologic patients, at least that is a little bit closer to our MDS patients. And so there have been a couple of smaller trials. So this is a pilot trial of 89 patients with acute leukemia who were randomized to a restrictive transfusion threshold at hemoglobin less than 70 versus a higher hemoglobin threshold at hemoglobin less than 80. And what they found is to maintain the liberal group, there was a requirement for more red cell units, as would be expected, with no difference in terms of fatigue scores or bleeding scores in this group. There's also been a larger study from our colleagues in Ottawa looking at 300 patients with hematologic malignancy that have undergone stem cell transplant, and again randomized to a restrictive transfusion threshold with a hemoglobin of less than 70 versus a hemoglobin less than 90. And again, just showing that the group that required liberal transfusion threshold required more units of red cells, and again, no real significant difference in terms of the quality of life changes with these thresholds. There was also no difference in secondary outcomes, including transfusion-related mortality, hospital length of stay, ICU admission, and hospital readmission. So what's different about our outpatients? So there are a few things. One is that MDS patients are often older with more comorbidities. Patients that are outpatients, want less disruption to their daily life and fewer return visits to the hospital. And possibly the transfusion-related outcomes, which we often look at in inpatients as measuring as mortality, for example, perhaps that's not the most important outcome for patients who are outpatients. Perhaps they're more concerned about their quality of life in that setting. So what can we use then to guide transfusion in outpatients with MDS? Well, we can look at consensus. So we can look at surveys of physicians. So here on the left is a survey of US physicians taking care of hematological patients. And what you can see here are, the question is, what is the hemoglobin threshold at which you would transfuse a patient? And you can see perhaps in the ambulatory setting, it's a little bit higher in terms of hemoglobin of 80 versus 70. In a study of Australian and New Zealand physicians looking at their MDS patients specifically, the commonest thresholds that they saw were again very similar in the 70 to 80 range, and for patients with a prior myocardial infarction, hemoglobin less than 90, with the goal of a post-transfusion hemoglobin closer to 90 to 100. In terms of the consensus, this was a panel of 13 expert MDS clinicians, and they really weren't able to reach much consensus aside from stating that in patients with MDS who had no end organ effects of anemia, transfusion could be withheld until the hemoglobin, or for patients with hemoglobins of 75 or higher. So all sort of in that benchmark. So, not a lot there, and it does lead us to question, what should be the goals of red cell and platelet transfusion for patients with MDS. And so this is a really nice article from Drs. Erica Wood and Zoe McQuilton based on the ASH presentation in December of this year. And what they looked at were some of the goals, which would be to improve acute and chronic symptoms of anemia in terms of fatigue, shortness of breath, chest pain, minimize major complications of severe anemia, and improve functional outcomes. And though we might measure these with hemoglobin hematocrit, which is what we're used to in inpatients, perhaps we should really be looking at some functional measures using standardized tools to look at fatigue scores and walk distance and grip strength, or even self-report, with the hopes that we will control symptoms, increase the functional status, and increase really the patient's ability to participate in work or social or community interests, just live their lives as they choose to live it. So, when we look at the literature, the retro study is really an important contribution because it's actually one of the first studies that has looked at the effect of transfusion on outpatient functional status. So this study looked at 208 patients with benign or malignant heme-onc diagnoses, and they looked at functional scores. So here on the right, you'll see the top here is looking at the walk test distance and looking at how far patients could walk pre and post transfusion. And the white bars are for patients who had no cancer therapy within 4 weeks versus those that did have cancer therapy. And here we have fatigue score and dyspnea or shortness of breath scores, and you can see that there's a slight improvement with the post-transfusion. But if you take a look at these waterfall plots here on the right, so this each little bar corresponds to a patient, and it's really ranking the patients from the worst scores all the way to the best improvements, pre versus post. And interestingly, you can see that, you know, about 50% of the patients improved with transfusion, but there was about 20% who did not have improvement. In fact, they were worse. And then a group in between who actually had no change in terms of their functional scores or symptom scores with transfusion. So it really brings up the whole question of, you know, how do we know that we're, you know, making a difference with transfusion? Are we just exposing patients to risk? You know, how do we tell if a patient's going to actually improve when we transfuse them? And so in this study, they looked at predictors of response. A hemoglobin of greater than 80 that was maintained for 1 week post-transfusion seemed to be a predictor of better responses. And not surprisingly, not having cancer therapy or having a hospitalization during the study period also unmasked the benefits of transfusion. So, you know, maybe we should ask the patients. And so this is a study that was led by Dr. Rena Buckstein, who is a national MDS expert here at Sunnybrook. And so she designed a web-based survey that was sent out in the US, Canada, and the UK. And 475 transfusion-dependent red blood cell patients with MDS responded. And so these were a couple of the themes that I picked out. But the median hemoglobin threshold that was used in these patients was 80, so very similar to what the consensus amongst the physicians were. Although 40% of patients preferred that they would be transfused at a higher hemoglobin and 15% at a lower hemoglobin. Fatigue and shortness of breath were the most common symptoms and had the most negative impact on their quality of life. And finally, while there was a majority that felt better, again, very similar to the retro results, 20% actually felt worse post-transfusion for a couple of days, and 7% had really no change in terms of their symptoms. I think another important finding that is becoming more prevalent across medicine is this understanding of other social determinants of health. So about a third of patients in this survey reported experiencing undue financial hardship because of transfusion dependence. So we're quite fortunate because I think we're just on the brink of starting to look at this question more carefully and clearly. So in collaboration and led by a protocol that was initially put together by Dr. Prika and Dr. Buckstein here in Toronto, we have collaborated with colleagues in the UK. And this is the first pilot study that looked at red cell transfusion thresholds and quality of life in MDS in the UK, Australia, and New Zealand, the REDS-1 study. And this looked at 38 patients who were transfusion dependent, and they had a run-in period. So they were all transfused for 6 weeks to reach a hemoglobin of 100. And then they were randomized at that point to restrictive transfusion thresholds. So this was to maintain the hemoglobin between 85 and 100 versus liberal to maintain the hemoglobin between 110 and 120. And that's the transfusion strategy listed there. And the pilot study was deemed feasible because there was more than 70% compliance according to the transfusion threshold in both arms. What was interesting is if you take a deeper look at some of the outcomes, the pre-transfusion hemoglobin, there was good separation between the two groups. Subtly, you can see perhaps there's more ups and downs in the green group, which is the restrictive transfusion threshold group versus the liberal group. And clearly, so the red dots here are the number of transfusions that patients required in the liberal group versus the blue dots in the restrictive group. There was clearly an increased need for number of red cell units in the liberal transfusion group. And so when the quality of life measures were applied, overall, the liberal group did have a slight trend to having better quality of life scores, although it was not statistically significant. And one wonders whether this may have been due to some of that amplitude or that up and down in the restrictive group that may have led to some of sort of decreased scores in terms of the quality of life. So the ENHANCE study was the Canadian pilot done in Toronto and Hamilton. And so that's been completed and is in the process of being written up, but was published as an ASH abstract in Blood. And this looked at 30 patients who had transfusion-dependent MDS with no run-in period and were randomized to restrictive versus a liberal transfusion threshold. And very similarly, you can see here the separation in hemoglobin between the liberal group and the restrictive group, although it was not as significant, only about a 10-point difference. And we saw very similar findings, and that was that there were more transfusions in the liberal group compared to the restrictive group. And again here, you can see that the red line is the liberal group in terms of their quality of life scores, with higher being better, and it was slightly higher compared to the restrictive group, but again, not statistically significant. I think one of the most important findings, though, is this mean change in ferritin. So, you know, with this increased need that we saw in both pilots, the ferritin was not noted in the UK study, but we measured it here, and there was quite a significant difference. So there is a cost to increasing transfusion with the liberal transfusion threshold, and this was just over 12 weeks, and often these patients are transfused over long periods of time. So that's something that we do need to be aware of. As well, there was one Aloe antibody that was developed in the liberal arm and one febrile non-hemolytic reaction. So what can we use to make the transfusion experience safer and better for the patient? Apologies, we have some overhead calls here at Sunnybrook. So in terms of iron overload, you know, as I've mentioned earlier, MDS in and of itself leads to ineffective iron metabolism due to the ineffective erythropoiesis, and then that's added and contributed to further by transfusion. So patients need to be screened, looking for a ferritin greater than 1,000, and particularly after they've received more than 15 to 20 red cell units. Iron overload has been shown to be associated with reduced survival, and in addition, with the Telesto RCT, it's also been shown that iron chelation can actually lead to improvement and prolongation of event-free survival compared to patients who do not receive iron chelation. There are also transfusion reactions. So listed here, some of the transfusion reactions that can occur, which this is from an area in France, and doesn't seem like there are any particular differences in terms of the frequency, except that they, of course, happen just as often as in inpatients. So they have febrile non-hemolytic reactions, allergic reactions, TACO, and as well as red blood cell alloimmunization. So on that topic, the rates of alloimmunization are significant. So studies estimate anywhere from 11% to 57%, although these higher rates are usually reported in smaller studies. It is associated with an increased number of units. So in those patients who did develop antibodies, about 70% of them developed by 20 units of transfusion. And this is from a study that we've conducted here to look at the types of antibodies, and as noted, as commonly, just as in the sickle cell population, about 75% are in the RH and Cal blood group systems, and that's exactly what we saw here. We know that alloimmunization decreases with disease-modifying therapies and increases with, and after alloimmunization, often transfusion can actually increase in intensity, interestingly. The rates of autoantibodies is also significant, occurring in about 4 to 10%, and occurs more commonly in Aloe immunized patients, with 40 to 45% having a positive DIT. And so this has consequences, of course, for the lab. So we may see delayed hemolytic transfusion reactions. These autoantibodies can at times be pathological and lead to autoimmune hemolysis. Even if they are delayed serologic transfusion reactions only, they lead to significant challenges to resolve in the transfusion lab. And that then in turn causes longer time to prepare the red cell units for transfusion, and often more trips for the patient, because we're trying to get their groups and screens done earlier than the same day. And so we've got repeated recurrent visits for the patients. So, for prevention here at Sunnybrook, for a number of years, we have prophylactically been providing antigen matching for RH, CE, and K to see if we can actually prevent these alloantibodies and, also reduce the amount of investigation that we need to do in the blood bank. So we did work again with Dr. Buckstein on the MDS registry patients, and we compared patients who received transfusion at a site with prophylactic antigen matching for RHCEK, and that was essentially at Sunnybrook, compared to those patients who were transfused at other sites. And when we looked at all clinically significant alloantibodies, the rates were 11% versus 23%, so not statistically significant. But when we looked at the allo immunization rate for RH and K alloantibodies, it was 7% versus 22%, which was clinically significant. And as expected, no patient that was receiving RHK matched blood prophylactically developed RHK alloantibodies. So alloimmunization can still occur. For example, we see these cases through platelet transfusion and through, and of course, the development of non-RHK alloantibodies, but we found that this policy has actually been quite helpful for our patients. So, going back to the new hematologist that's at your center, who's so kindly and thoughtfully thought about how best to manage her patient, I think our response would be, at this point, we don't have current guidelines for MDS outpatients, but we're working on generating evidence for it. It's reasonable to use a hemoglobin of 70 to 80 and adjust considering the comorbidities of your patient and the impacts on quality of life. And consider if available and resources are available to provide prophylactic RHK matching for transfusion-dependent patients. I think it's really important to explore within your context ways to simplify the process. Can we offer same-day cross-match? Is there a way to do home groups and screens? For example, UHN has this program available at least at outside labs aside from the hospital for sickle cell patients, and also try to explore ways to capture quality of life and what is important to patients. So in the last few minutes, I'd like just to say a few words on chronic platelet transfusion in MDS outpatients, because that is also a significant burden. MDS patients do have thrombocytopenia. Just like transfusion dependence, there is an adverse prognostic factor, or thrombocytopenia is an adverse prognostic factor. MDS patients die from bleeding in about 9 to 13% of the cases. And looking at this MDS registry in Australia, about 50%, so half of patients, will require at least one platelet transfusion during their course, and 9% may go on to develop HLA-matched platelets, or require HLA-matched platelets for platelet refractoriness. We have guidelines, again, mostly based on inpatient studies, which are concordant to provide prophylactic transfusion at platelet counts less than 10. And these are similar to the ASCO guidelines, but there is, in the ASCO guidelines, a comment about therapeutic platelet transfusion. So that is platelet transfusion specifically for patients who are bleeding and not prophylactically, and that this may be something to consider for chronic, stable, severe thrombocytopenia patients with MDS and aplastic anemia who are not receiving active treatment. So again, we can look towards consensus about what physicians are doing, and this is a survey in the Netherlands, and they looked at when physicians were using prophylactic platelet transfusion for MDS patients, and found that if they were on treatment, most physicians would treat with platelet transfusions. If they were on no treatment, then they would move towards a more therapeutic platelet transfusion strategy. Also, which was quite prevalent, was the use of tranexamic acid, particularly if they had suspicion or suspected that the patient had an increased tendency to bleeding. We've also looked at this, or Dr. Buckstein and Dr. Vijayanthira here again at the MDS registry, looking at 99 patients who had severe thrombocytopenia with a platelet count less than 20, and looked at 4 groups who were treated with either tranexamic acid alone, tranexamic acid with prophylactic transfusion, or prophylactic transfusion alone, and no treatment at all. And this is a retrospective study, so a lot of limitations. The groups are not entirely the same or treated necessarily the same. But the important point was that there was no significant difference in grade 3 to 4 bleeding, and that about 70% in both the first group here and the no transfusion group did not require any platelet transfusion during their course. And so, you know, we need to think a little bit about how best we can try to predict or work towards methods by which we can predict, you know, which patients we think might bleed in order to avoid having them have routine platelet transfusions that may not be offering benefit. Tranexamic acid, I'll make a quick point here, and you know, we use tranexamic acid a lot in MDS patients. This is a study that was presented at ASH in December, looking at tranexamic acid versus placebo every 8 hours during chemotherapy and stem cell transplant. So this was an inpatient study, and I think what was surprising and somewhat disappointing was that there was really no difference in terms of the proportion of bleeding or death between those patients who received tranexamic acid and placebo. And so again, perhaps it's not something that we should be giving routinely to everyone, but trying to sort out who may benefit if there is a group that benefits from tranexamic acid. So in summary, MDS patients carry a significant transfusion burden with impact on quality of life, prognosis, and resource utilization. The evidence for transfusion indications is developing in patients with MDS. And, you know, we struggle with how we can tell if we are over or under transfusing patients in the outpatient setting. And, you know, that's something that I think we just really need a little bit more data to sort of help guide us. So I think this is a call to action. It's time to focus on this outpatient setting, trying to understand how we optimize outcomes and the care and the experience for patients with MDS and all of our chronically transfused patients. So with that, I really like to thank you for your attention and say thank you to Dr. Rena Buckstein and Christine Turdy-Gazdowicz for their advice on this presentation. So thanks so much for your attention.
Thank you very much, Dr. Lin. That was a great presentation, and really nice to hear some information about that group of patients who uses a significant amount of blood. I think in the interest of time and on the experience of this morning session, we'll probably not take questions until the question and answer panel. If that's okay with you, will you be able to return for that?
Yep, happy to, no problem.
Okay, thank you so much. All right, Dr. Anani, I think I'll pass it on over to you to introduce our next 2 speakers, and Julia can move to hand control over to Melanie. Thanks very much.
Perfect. All right, we have 2 speakers, and their talks are going to be kind of a continuation of each other. The first one is Melanie, who's been working in the transfusion medicine service at the Ottawa Hospital since 1993, where she's been a charge technologist since 2000. In 2019, she became a regional manager for transfusion medicine, tissue typing and DNA, and the molecular oncology diagnostic lab for the Eastern Ontario Regional Laboratory Association. In 2012, Melanie became a member of the Institute for Quality Management in Healthcare, or IQMH, Transfusion Medicine Scientific Committee. She has been involved in publications of many posters and peer-reviewed papers. Take it away, Melanie. We're looking forward to hearing from you.
Hi, thank you very much for that introduction, and super thank you for inviting me to talk about the topic of autoimmune hemolytic anemia and how we manage those samples in the lab. Specifically, we'll be talking about warm autoantibodies, and we're going to learn how they're processed in the lab, and then we'll talk about the cross-matching procedures that we use to ensure our patients have safe transfusion as possible. Both Dr. Mack and I will be talking about the same case. A 51-year-old male, previously healthy, presents with weakness, dark orange urine, rigors and chills, and shortness of breath. And for a healthy gentleman, his hemoglobin is quite low at 64 with some markers of hemolysis. Now, the worst case scenario is that this is going to happen on your night shift when you're most likely going to be alone on shift. If you're in a large blood bank like ours, you are alone. If you're in a medium or small site, you're probably alone and working a CBC machine, coag machine, and chemistry instruments. So here we get a type-in screen, as I said, arriving at 2 a.m. and a 2-unit red cell order. The ABO-RH typing is over here on the right-hand side, and you can see that it's pretty straightforward. He forwards as a group A, no reactivity with the anti-B anti-sera, and reverses as a group A as well. So no reactivity with A cells, but a nice strong 3+ with B cells. So he is A positive, and this is very typical of patients with warm autoimmune hemolytic anemia. There's no interference usually with the ABO typing. But here is the anti-human globulin test. We've set up his plasma with a 3-cell screen, and he's strongly reactive at 3+ with each of those cells. The first thing we're going to do is set up a whole panel of cells, and in this case we have 16 cells, including an auto control. And very consistently down the row, he's reacting 3+. His plasma does not like these red cells at all, but it includes his auto control. It is 3+. That leads us to do a direct antiglobulin test, and his DAT is positive for IgG. One of maybe the good things to note is that his auto is positive, and this is really leading us to think that it's a warm autoantibody. It's almost more scary if this auto control was negative, because the first thing that I would think is that he has an antibody to a high incident antigen, and that's almost harder. So the auto control is positive, so we're really thinking an autoantibody, but is that the only thing that's there? We're really worried that there might be an underlying clinically significant alloantibody that's being masked by this highly reactive autoantibody. So we have to remove that interference to see what's underneath. My first thought is that we should call the transfusion medicine physician and get them involved right away. It's best to have the conversation between your TM physician and the physician in the emergency department, because they can determine whether it's prudent to go ahead with transfusion, knowing it's going to be incompatible, and knowing that we don't really know what's underneath the auto antibody, or can we wait and work it up more fully. Patient history is really important, especially transfusion, because some of the tests that we're going to be doing really rely on the knowledge of whether this patient has been transfused or not. Pregnancy is always good information to have, as well as medication list. In the cartoon down here, it kind of shows what's going on. So we have a patient, and these are his red cells, and they're coded by the autoantibody, creating a positive DAT. But what we say is when these red cells get oversaturated with autoantibody, it spills into the patient's plasma. And you can see in the middle cartoon, it's showing that autoantibody in the plasma. On the right-hand side is what we're afraid of, that we have the autoantibody, but then the red alloantibodies are there as well, and they're being masked by the autoantibody. So that's what we really need to determine. If this is urgent, what to cross-match. So many a times, I'm sure you've heard as well, that a physician will say, well, just give me O-negative red cells. It's the universal donor. But in this case, it really isn't. We would honor the ABO and the RH, and you can see on this red cell, the top right-hand corner, the ABO antigen systems are there, as well as the RH. But there's many other blood group systems, and within them, antigens. And we have to keep that into consideration, because patients do develop antibodies to those other antigens, and they can have transfusion reactions if they have the antibody, and we transfuse them, those cells that are positive for the antigens. So should we go ahead and cross-match ABO and RH matched only? Well, we know all the cross-match units are going to be incompatible because we saw that in the panel. And we are worried if there is that Aloe antibody there. So in the cartoon here where we have the where's Waldo, Waldo is somewhere in with all his friends there, but we just can't see him. If blood is needed urgently and there is time to wait, our first plan of attack is to phenotype the patient for the common antigens. And again, this is where it's super important to find out if your patient has been transfused or not in the last 3 months. Because if he has, then you really shouldn't be performing the phenotyping on him because he has a dual population of cells. He has his own cells and the transfused cells. You can see here, though, if this patient was not transfused, we would type him for the extended RH. We already did the D-typing, which tells us if he's RH positive or negative, but we also do big C, little c, big E, little e, big K, JKA, JKB, FYA, FYB, big S, and little s. It's important to remember that your patient's DAT was positive. So having a positive DAT might interfere with some of these reagents. I know that the Duffy A and the Duffy B often are AHG reagents. So you would have a false positive if you didn't recognize that you had to treat your red cells before using these antiserous. Then from there, we will cross-match red cell units that are phenotyped similar to what our patient is. And that's not always easy. Yes, it does avoid an Aloe antibody. So if your patient was Kel negative and he did have anti-Kel, but you couldn't see it, at least you're giving Kel negative blood and you would avoid a transfusion reaction and avoid that Aloe antibody. But sometimes it's a difficult match. So depending on the pattern of phenotype, the patient might have a really rare full phenotype to cross-match. An example would be if the patient was negative for the little e antigen. Right away, the cross-match compatibility is reduced to only 2%. Do you need to order in from the Canadian Blood Service? Perhaps you don't have the time or the means to phenotype your donor units. Or if you did, you might not have those on your shelf. So it would take time to order from the Canadian Blood Service. We're lucky we live in Ottawa and our Canadian Blood Service is about a half-hour courier call away. Then in discussion with the transfusion medicine physician, might you drop some antigens and not honor them? For us, if we have difficulty in finding blood that's totally phenotype similar, we might, in consultation with the TM physician, drop the S's, for example, or maybe the Duffys. Always honoring, of course, the ABO, and the RH, and the Cal. You have to remember, though, even if your patient's phenotype is done and the units selected are phenotype exactly matched, the red cell cross-match is still going to be incompatible because they have an autoantibody that's reacting with everything. Now, best case scenario is that we're able to process the sample longer and absorbing out the autoantibodies to reveal that Aloe antibody underneath. And to do that, we use the patient's own red cells to absorb up the offending warm autoantibody, as you can see in this drawing here. So if we think of our autoantibody as the paper clips, and the Aloe antibody that we want to leave behind as the sheets of paper, and the red cell is the magnet here. So we take the patient's red cell and absorb out the paper clips or the autoantibody, thus exposing the Aloe antibody left behind in the plasma. So importantly, the patient again must not have been transfused in the last 3 months because you are going to be using red cells that are of dual population, the previously transfused cells as well as his own. And the risk is that you're absorbing out an Aloe antibody. If there could be a safest type of adsorption, I like to think that this is because there's no risk of absorbing out an Aloe antibody because you're using the patient's own red cells as the magnet. In this drawing here under A, this is our initial sample, and you can see that the patient's red cells are coated with the autoantibody in purple, and we have the autoantibody floating around in his plasma, but we also have the Aloe antibody, and in this case it's anti-Cal. In the middle screen for B, we've taken the patient's red cells and adsorbed up or used it as a magnet to absorb out all those autoantibodies, leaving behind the Aloe anti-Cal in pane number C, the adsorbed serum. So we take this serum and set it up against a panel of red cells, and we would be able to see the pattern of reactivity and the specificity of anti-Cal in his plasma. It takes time though. It might seem simple there, but in this diagram, it's saying that it's about just over 3 hours, but truly it's closer to 4, maybe even almost 5 hours, because there is some preparation that you have to do. But basically, we take the patient's plasma and we add it back to his own red cells and incubate at 37 degrees for about an hour. And during that incubation time, it's good if the technologist kind of mixes it or turns it over every once in a while to make sure that there's good mixing of the plasma and the antibodies and red cells. After that incubation, you're going to take that tube and we centrifuge it really hard for 5 minutes, really separate that plasma. Then you take the separated plasma and add it to your next tube, a new tube of autologous red cells. And again, you incubate it for about 60 minutes at 37 degrees with gentle mixing. After that incubation, again, you're going to centrifuge, remove the plasma, and add it to a third tube of your patient's red cells. Incubate at 37 degrees for 60 minutes with gentle mixing. And then finally, after that, you do another really hard spin, take the plasma. All these red cells aren't good anymore for you, so you do have to discard them. And you take that plasma and you're able to set it up against a panel of red cells to see if there is any alloantibody underneath and if you've removed your autoantibody. I really always like to do a 3-cell red cell absorption. And I find that any less, you're probably not going to absorb out your autoantibody sufficiently enough to reveal any potential alloantibody underneath. Now, we mentioned that the DAT was positive. We already know that the patient's red cells are coated with this autoantibody. And in this picture, I tried to show why that's a problem. So we have a magnet here that's totally covered in nuts and bolts. And then we have all the nuts and bolts kind of in the plasma. And the little widget at the bottom right-hand side that looks like gold, that's what I want to expose, but I can't because there's so many nuts and bolts. I have to clean off the red cell, or in this case, clean off the magnet to make it a really good sponge or a really good attractor of more autoantibody. So I have to dissociate the autoantibody off the patient's red cell. And we do that by using ZAP, a mixture of papain and DDT. And that's going to wipe off all the autoantibody from the red cell, making it a clean red cell, making it a good sponge to absorb up the autoantibody. And using the papain, it's also going to enable a really good uptake of the autoantibody. So this takes time too. It probably takes about an hour to clean off your red cells. So again, here you've cleaned up your red cells, and then at the very end, after your 3 adsorptions, you end up with a plasma that you set up against a panel of red cells. And then in our Where's Waldo game, you can see that Waldo is standing there in the field, somewhat by himself, but certainly we're able to see it. So he's our alloantibody, and we're now able to see him. So here's our panel from the case that I explained, and you can see again that whole line of reactivity under the AHG. So his plasma is reacting with all these red cells very strong, including his autocontrol at the bottom. And then in the red, it has the adsorbed plasma. And seeing some negative results really proves to us that we did a good job of adsorbing out that autoantibody from his plasma. So it's totally gone. But you can see some 2+ reactions with cells number 7, 10, and 13 as highlighted with the yellow. So once we removed that autoantibody, we were able to reveal that the patient indeed had an alloantibody, and the specificity is anti-cal. Now that's an autoabsorption, but what do you do if your patient has been transfused or if you don't have any pre-transfusion specimen red cells available? And this can often happen even if you have a brand new sample and your patient hasn't been transfused, because these patients usually don't have a very high hemoglobin or hematocrit. So when we get these tubes of blood in the lab, we have lots of plasma to work with, but not very many red cells. Sometimes you might want to call up and ask the nurse to redraw a couple of tubes, but the patient's already been poked so much and is probably already anemic. So the thing to do is to do an alloabsorption. There's always a risk, though, that you may absorb out clinically significant alloantibodies. Remember, I said the autoabsorption is the safest thing to do. If you have pre-transfusion phenotype, so maybe you do have that brand new fresh tube and the patient hasn't been transfused, but you don't have a lot of red cells, you are usually able to do the phenotypes. And if you are able to do that, then you're able to select red cells that are phenotypically identical to the patient and do the absorption using those cells. If not, you're going to have to do a differential absorption. It's very complex, and it's one of the most complex things that we do in transfusion medicine. And as I explained before, it's very time consuming. And then I have this little thing, I find it fun. Anyone who is very interested in doing Sudoku or any kind of wordplay, it's fun, but the little man there with his eyes kind of rolling back is usually what the technologist is thinking when I'm not the one working on the bench, but trying to say that it's fun. So to do a differential alloabsorption, we use multiple homologous red cells with known antigens. We're going to ZAP treat those red cells because the good thing about ZAP in this situation is that it's going to render the red cells negative for some of the antigen systems that we're worried about for the not absorbing out the alloantibody. DDT destroys the KEL system, so we don't have to worry about inadvertently adsorbing out any antibody in the KEL system. PEP-pain removes Duffy, both Duffy A and Duffy B. So again, we don't have to worry about adsorbing out any allo antibody in the Duffy system. We select cells that are R1, the second cell is R2, and the third cell is little r. So again, differential adsorption using 3 different cells. We have to ensure that at least one of those cells are negative for the JKA antigen, and another one is negative for the JKB antigen. Here, this diagram shows what we're absorbing out and what we're leaving behind. So if you see here on the left-hand side, we have our 3 cells, R1, R2, little r. So if I took my patient's plasma and I absorbed with the R1, the potential antibodies, alloantibodies that I would be removing are anti-D, anti-C, and anti-e. But on the right-hand side, you can see left behind in my plasma would be an allo c and an allo anti-big E. And if I did it with an R2 cell, left behind in my plasma would be an anti-big C, anti-e. Taking my plasma and absorbing it with a little r, it leaves behind an anti-D, anti-big C, and anti-big E. So these are 3 parallel adsorptions that I'm doing all at the same time. And then, as I mentioned, one of those cells above should be negative for the JKA antigen and one should be negative for the JKB antigen. And you can see what antibodies are left behind there. So just as I said, anyone who really likes doing Sudoku, this is for you. This is our panel that we had before. And here's the column where our autoantibody was reacting with every cell presented, including his autocontrol. And then here is our allo-adsorbed plasma. With cell number 1, we used that R1. Cell number 2, we used R2. And cell number 3, we used little r. And in that diagram, I did say that with cell number 1, we would be adsorbing out an allo big C. With cell number 2 and 3, we would be leaving allo anti-big C behind. And that's exactly what we did here. So with the adsorbed plasma, after adsorbing with the R1, everything is compatible. Our autoantibody has been adsorbed out, that's a good thing, but everything else has been adsorbed out. But with the plasmas that were adsorbed with cell number 2 and 3, something was left behind. And again, almost like Sudoku, when you go and look at the pattern of reactivity, it shows reactivity with anti-big C. And that makes sense because here it's compatible. We knew that we were going to adsorb out anti-big C, and here we left it behind. Now, the cautionary tale that I have, as I said, that's fun, but it's not without risk. And I do have a sad story that we had about 10 years ago where a patient was coming in and being transfused every 2 weeks. And this week, his panel cells were all positive, including the auto. The DAT was positive, and unfortunately, the tech failed to recognize that there was mixed field in the DAT. And his LU8 was all positive. We did the differential alloabsorption that I explained in the previous slides, and it absorbed everything out. The patient was transfused with 2 units of red cells that were cross-match compatible with the adsorbed plasma, incompatible with his neat plasma. The patient was sent home, and he didn't really tell his nurses or doctors, but he suffered at home with fever and lower flank pain. He came back, and for a few times we performed the alloabsorption, transfused him with blood that was incompatible with his plasma, neat, compatible with the adsorbed differential adsorbed plasma. And then it was just by chance that after a couple of months, he came back, and the technologist happened to choose a panel that was similar to this. And when she set it up with the neat plasma, you can see that there is compatibility with cell number 13. Everything else is positive. Something that's really important to note, especially for new technologists, is that when you look at the auto control, it's only 1+. You should always compare your auto control to the reactivity of the cells above. It's a hallmark that this was only 1+. It means that it's not as strong. It probably means that there's not the same amount of antigen positive cells in his auto control. Remember, he was multiply transfused, so he has his own cells, but he also has transfused cells. And after looking at this panel, you can see that he has an Aloe anti-Lutheran B, which was really unfortunate. We felt horrible about it, and it really scared us for a few years to think that when we were performing differential Aloe absorptions, always tried to make sure that we had panels that were negative for antigens of high incident. But it's hard, and even trying to find this panel sheet for this talk, we have 5 panels on the go at our hospital, and finally I was able to find one that had a Lutheran B negative panel cell on it. But again, Aloe absorption is not without risk. Then we go to cross-matching. So the question is, and the debate is, because it's not standard across Ontario, do you use the neat plasma to cross-match, or do you use your adsorbed plasma? Knowing that the neat cross-match would be incompatible, and you should label your units as such. Adsorbed plasma is going to be compatible. Regardless of which method you use, we always cross-match phenotypes similar to have the patient avoid making those Aloe antibodies. We will not redo the Aloe absorption repeatedly until we see a difference in the DAT, or if we have to transfuse the patient phenotype incompatible. Now, warm autoantibodies with specificity also kind of throw a wrench in things. Most warm autoantibodies show panagglutination, but if there is specificity showing, it's usually within the RH system, and it's our experience that it's often auto-anti-E-like. And that poses a problem when you're trying to transfuse someone that has an auto-anti-E-like autoantibody, what to transfuse. Our policy is to transfuse phenotypes similar. So this patient would get little E positive blood, but they would be incompatible. If we cross-match little E negative blood or R2R2, it would be compatible. But R2R2 blood is only 2% of the population, and one could argue that that blood should be reserved for patients that have Aloe anti little e that are most often clinically significant. Usually these patients are negative for the big E antigen, so if I give little e negative or R2R2 blood, I would be exposing them to double dose antigen, and they could make an Aloe antibody to the big E antigen. I did find this in the AABB most recent technical manual. It does say if active hemolysis is ongoing, blood lacking that antigen should be selected. So in that case, and it is a conversation with your TM physician and the ordering physician, in that case, that means that we would be selecting R2R2 for transfusion. Another thing that's a bit controversy is this requirement from the IQMH TM122, which requires us to have the ordering physician sign off on issuing incompatible blood. We did get this as a non-conformance at our last IQMH because we were not giving the ordering physician our form to sign off. We really interpreted this that, say your patient had an anti-JKA and you couldn't supply JKA negative blood, we would get the physician to sign off on it. But we really didn't think that this applied to a warm autoantibody where we're giving phenotypically matched blood, although incompatible. So it'd be interesting to find out others' interpretation of this as well. In conclusion, working up patients for autoantibodies is, as you saw, very time-consuming, but really rewarding. It may delay transfusion, but as Dr. Mack will say in his next talk, is that always prudent? Large hematology centers like our own here, we process many patients throughout the week with autoantibodies. We're a hematology center, and so we see a lot of these patients. And so you really need your technical staff to be very well informed, that you need the support of your TM physicians, and very good operating procedures and policies, including when you're going to do such workup as an absorption. Are you going to do it overnight? Or are you going to wait for the day staff when there's more people in? So I'd like to take this opportunity to wish everybody happy MedLab Week and just say what an honor it is to be part of this community. And especially with our own group here at IRLA, I was able to witness firsthand everybody stepping up to the plate, whether it was going over and helping in the virology lab to even just unpack the thousands of samples coming in for COVID testing, and really proud to be part of the community. And it's never been a better time to be a lab worker, and we're finally, I think, getting the recognition that we're due. And I'd like to say thank you at this time.
Thank you very much. So our next speaker is Dr. Mack. He's a hematologist who focuses on benign disorders of the blood. He completed his medical degree at the University of Calgary, followed by training in internal medicine and hematology at McGill University, where he also completed a master's of epidemiology. Dr. Mack completed subspecialty training in transfusion medicine in the Harvard Medical School Joint Program in Boston, Massachusetts, and was an assistant director of transfusion medicine service at Mass General before joining the Division of Hematology at the Ottawa Hospital. He has an interest in clinical research with a focus on improving the clinical use of blood products, and has recently been appointed to the transfusion medicine service at the Ottawa Hospital. So thank you, Dr. Mack.
Great, thanks a lot for the introduction. Hopefully everyone can hear me okay and see my slides. Title of my talk is going to be taking over from the baton from Melanie, is to focus on autoimmune hemolytic anemia and transfusion part 2, still out of order, with a focus shifting from the laboratory aspects to more of the clinical side. I don't have any relevant conflicts of interest. And in terms of the objectives for my portion of the talk, two main objectives. One would be to discuss the indications for transfusion in autoimmune hemolytic anemia. And as part of that, we'll go through some of the data around the safety and efficacy of transfusion support. And then also review briefly some of the alternatives that have been looked at for to transfusion in autoimmune hemolytic anemia. So with that, as Melanie mentioned, we'll kind of be returning to this case that she talks about, which was a patient that was admitted to us recently. He's a 51-year-old gentleman who presented with weakness, dark orange urine, rigors and chills, and exertional dyspnea, and was found to have a hemoglobin of 64, which on repeat 12 hours later was falling to 54, with the rest of his CBC normal. He had a surprisingly low reticulocyte count for someone with that degree of anemia, and also had evidence convincing evidence of hemolysis with a haptoglobin of less than 0.1, so undetectable, and an elevated LDH, elevated total indirect bilirubin, and was Coombs positive with IgG and negative for C3, and he had the panagglutinin detected on screen, with most concerning of all units that were tested against his plasma being incompatible. And so this kind of a situation obviously raises a lot of anxiety, particularly among the clinicians at the bedside. There's a panagglutinin that's there. There's no compatible units, and the question is, what do you do? On the one hand, you might think, well, just transfuse the patient. It's going to he's going to feel a lot better. The clinician is going to feel a lot better with a higher hemoglobin. But the other side of things is that there's a legitimate concern that the transfusion might make things worse, and a transfusion reaction in someone who's already that unwell is the last thing that's needed. So how do we resolve these two things, and how do we come to a conclusion on what are the actual indications for transfusions? I think the big starting point to say here is that this is really kind of a space where there isn't a whole pile of data. Unfortunately, there aren't the equivalent of the large transfusion trigger or hemoglobin threshold trigger trials like the TRIC trial that's been done in this subpopulation of autoimmune hemolytic anemia. And so the rationale for RBC transfusion is really kind of similar to what's physiologically done for other populations, with the use of red cells to support the oxygen carrying capacity of the blood and maintain sufficient hemoglobin concentration to do that. And the physiologic rationale behind this is shown in this relatively well-known curve, I think, showing the relationship between the delivery of the oxygen delivery, or DO2, and oxygen consumption, VO2. And if we focus just on the top of that graphic there, moving to the right side of the curve, all the way up to where we start to see the curve kind of sliding down a hill there, is the relationship between delivery and consumption. And it shows that for the most part, our body has an excess of oxygen delivery capacity. And so up until a certain threshold, the amount of oxygen that's being delivered, or the capacity to deliver oxygen, is able to match what the body's oxygen consumption needs are. until it reaches that threshold where the delivery is exceeded by oxygen consumption, or falls below oxygen consumption, and then becomes very supply dependent. And that threshold is really kind of what we're trying to avoid in patients who are anemic. And the rationale behind why we would transfuse red cells is kind of explained by the equations showing what the DO2 is calculated using. And that's this constant of 1.34, which is the grams of oxygen that's carried by a hemoglobin, multiplied by the gram per liter hemoglobin concentration, and then finally the saturation of oxygen in the blood. And so if we're able to increase the hemoglobin concentration, we're then able to increase the amount of oxygen that's delivered by the blood and improve the oxygen delivery to then match the VO2. And unfortunately, fortunately or unfortunately, I guess every patient is going to have a different threshold where this anaerobic transition happens. And a lot of these transfusion threshold trials, like the TRIC trial, are using kind of an average or an estimated sort of average of something that's going to be keeping people well above that threshold. And in any given patient, that's the goal, is to keep them above that threshold and prevent them going into an ischemic situation where the supply is outweighed by the oxygen consumption. So that's why we would want to give RBCs to someone who's got severe anemia, whether it's from acute hemolytic anemia or otherwise, but particularly relevant for the acute hemolytic anemia patient. Now, there are certainly reasons to be cautious with transfusion, and some of them are shown here. One is that the mechanism of autoimmune hemolysis is the autoantibody that the patient has developed and is destroying their own red blood cells. And these autoantibodies are able to recognize antigens that are common to virtually all RBCs, and so there's no reason to think that transfused RBCs are going to be any less prone to the hemolysis from that autoantibody. And so the more RBCs we give, then the potentially more substrate we're giving for hemolysis, which could then lead to accumulation of the products of hemolysis, like free hemoglobin and RBC membranes, which have some toxicity and can be quite injurious to organs like the kidneys. The other concern is, as Melanie highlighted and explained quite elegantly, is that the autoantibody interference with routine screening really kind of subverts that pre-transfusion testing and may mask the presence of an Aloe antibody, raising the concern that giving a transfusion without that reassurance could lead to an acute hemolytic reaction due to an Aloe antigen on top of the already hemolytic process going on. And then finally, the availability of appropriate RBCs may be limited. This again will depend a little bit on how RBCs are being identified and selected, and particularly in situations where we're using phenotype matched blood products. If the patient happens to have a phenotype that is rare, it may be challenging to actually have an adequate supply to support transfusion. So there are all some considerations that need to be taken into account. And however, I think the important part here is to highlight that the concern about hemolysis really shouldn't be outweighed by the need to maintain adequate oxygen delivery. And transfusion support for these patients can be life-saving and may be necessary. And this point was really highlighted by this case series that was published a few years ago from a center describing 36 patients with autoimmune hemolytic anemia from a center in Germany. And they selected these patients because they all had autoimmune hemolytic anemia and were transfused. And of the 36 patients, 4 of them actually passed away due to their autoimmune hemolytic anemia. And when they looked into the reasons for why the autoimmune hemolytic anemia was able to ultimately claim their lives, the investigators attributed really kind of hesitancy around blood transfusion to be the underlying contribution to that. And they nicely summarized one of the medical notes that was actually in the patient's chart here. The younger patient here, patient number 2, was 34 years old. They described the patient was somnolent and hypoxic and didn't receive additional blood transfusions because the attending hematologist was of the opinion it would aggravate the underlying condition. And the following day, the patient was intubated, transferred to the intensive care unit at the hospital. On arrival, they had a metabolic acidosis, which was again indicated that they had passed over onto that anaerobic side of the DO2 VO2 curve, with decompensated hemolysis, a hemoglobin impressively low at 20 in equivalent in Canadian units, circulatory failure, and enlarged pupils. And kind of really to underline, I guess, how much anxiety there can be around transfusions, they felt it was safer to proceed with splenectomy rather than to actually transfuse this patient, and she unfortunately died. So, so there's certainly a lot of concern around transfusions, and I think one of the challenges, there really isn't a whole lot of data to really guide some of these decisions. But there is some data, and I think that data overall is fairly reassuring. And I want to walk through sort of three considerations of some of the data to support some of that reassurance. One is the relationship between transfusion and transfusion reactions in patients with autoimmune hemolytic anemia. And this data comes from a retrospective cohort of patients from a single center in China, where they looked at 450 patients who were admitted with autoimmune hemolytic anemia with hemoglobins less than 110, and along with hemolysis had to have the positive DAT as part of the autoimmune hemolytic anemia definition. They categorized the patients based on the severity of anemia. So they had some patients who were very severe with a hemoglobin less than 30. It was a small minority, 3%. About a third of patients with severe anemia between 30 to 60 grams per liter. Moderate anemia, and about half of them with 60 and 90, and then the rest made up by mild anemia with hemoglobins over 90. And in this center, the RBCs were being selected for transfusion using the least incompatible methods, so not using adsorptions or phenotype matching, but just using the cross matching and picking the ones that would have the least, the lowest scores, a 1+ or a 2+ incompatibility. And what they found overall was 60% of these patients were transfused. Most of the transfusions, or most of the patients with a very severe or severe anemia, less than 60, were transfused, 92% of them. But a fair number of patients with the hemoglobins in the 60 and higher range were also transfused, almost half of them. And when they evaluated the transfusion episodes, they had 1,112 episodes that they could evaluate, with 2,509 units being transfused across those episodes. And they were able to look at 885 of those episodes where they had complete documentation of vital signs around the transfusion and descriptions of how the patient was doing. There were overall a median of 5 units transfused per episode. And most of the transfusions were successful according to how they defined success, which was relatively low bar of just a 5 gram per liter increase in hemoglobin, which happened in 2/3 of the patients. Now, transfusion reaction incidence was quite relatively low. It was 1.6%. So of those 885 episodes, they had just 13 febrile reactions, 1 allergic reaction, and 1 what they called somatic reaction, which involved headache and increased blood pressure. And none of these patients went on to develop any more significant clinical deterioration. There was no hypotension. There was no real severe reactions that were noted. So some data to sort of provide some reassurance that at least when we're transfusing patients with autoimmune hemolytic anemia, the risk of having a major transfusion reaction doesn't seem to be all that high. Alloimmunization is a very big concern, both from the point of view of being able to detect allo antibodies, but also from the point of view of actually being able to provide units that might prevent alloimmunization. And some reassuring data, I would say, comes from this retrospective cohort study. It was a multinational study that was put together by the BEST Collaborative. In this study, they looked at 8 centers across 5 countries that included 1 reference lab and 7 transfusion services, with 6 of the 7 transfusion services using the PAM strategy of prophylactic antigen matching. So just trying to select units based on the antigens that the patient is missing. And they looked overall at, they had 122,245 patients that were included in this overall cohort based on having an IAT performed at one of these centers. And then they further winnowed that down to look at only the patients who had a warm autoantibody identified. They excluded patients who had a drug-induced autoantibody who had been treated with an anti-CD38 therapy or with sickle cell disease. And when they looked at the patients with the warm autoantibody, they found that the prevalence was overall about 0.46%, and excluding the reference lab with the rationale that it might be enriching for the warm autoantibody occurrence or incidence. In the transfusion centers, it was even lower at 0.17%. Of the patients with warm autoantibodies, they were able to have kind of complete serologic and transfusion information on 1,002 patients. and 2/3 of them approximately had a warm autoantibody identified in isolation, and the remaining third had a warm autoantibody identified along with an Aloe antibody. 631 of those 1,000 patients were transfused, 390 using the PAM strategy of antigen matching, and 241 using a no PAM strategy. Unfortunately, they weren't able to provide details on what the no PAM strategy entailed, whether those centers used allo absorptions, auto absorptions, just least incompatible blood. Those details aren't available, unfortunately. And what they found was that patients with the warm autoantibody with an allo were more likely to be transfused, with 72% versus 60% in the patients without an allo antibody, and were more likely to receive more transfusions, or 17.5 units on median versus 13.8. And when they looked at how effective the PAM strategy was at preventing allo immunization, they found not really much of an association between it and the allo immunization risk. So overall, they found 15.1% of the patients that were transfused who they had subsequent serologic information on an IAT done 30 days or later to allow a window for antibody development to occur. 15.1% overall had made a new antibody. And comparing patients who had the PAM strategy versus those who did not have the PAM strategy, there wasn't a difference in the proportion of patients that had that 14.6% with PAM versus 15.6% without PAM. And the using a regression model to adjust for factors such as age, sex, presence of autoimmune hemolytic anemia or not, they found that the odds ratio was about 1.46 with intervals crossing 1, so not really able to say there's any association between PAM and subsequent alloimmunization. So this is one of the only studies that's really evaluated different blood bank strategies for safely transfusing autoimmune hemolytic anemia. Another thing to note from this study was features that, they looked into features that did predict whether or not someone would go on to develop an allo antibody. And the factors that came out were being a female gender. So patients that had developed a new allo antibody were more likely, more of them were female, close to 70% versus only 50% in the patients who didn't go on to develop a new antibody. Patients who had clinical autoimmune hemolytic anemia were actually less likely to go on and develop a new allo antibody. So only 14% of the new allo antibody group had autoimmune hemolytic anemia versus 30% in the patients who didn't have a new allo antibody. And having had a prior allo antibody was also a risk factor for them having a subsequent allo antibody or subsequent sensitization event, with 50% of the patients versus 37 who hadn't. Just to highlight again that the important caveat to the study is that this looked at patients with warm autoantibodies in isolation, so they didn't have to necessarily have a hemolytic anemia going on in the background. So it might kind of skews a little bit or a bit of a selection bias against maybe the autoimmune hemolytic anemia, but reassuring at least that they weren't seeing that autoimmune hemolytic anemia increased the risk of alloimmunization. So those three studies kind of give a bit of data to provide some reassurance about transfusion support in autoimmune hemolytic anemia. What about the efficacy of RBC transfusion? So some data to shed some light on this came from the study from South Korea, where they looked at 161 patients with autoimmune hemolytic anemia who had been transfused between 1 to 5 RBC units in a single episode. In this center, they were using adsorption procedures to be able to select RBCs for transfusion. And what they did was they looked at the baseline hemoglobin, total bilirubin, and LDH, and then repeated those daily for 7 days to follow. And they compared the patients with autoimmune hemolytic anemia to 2 control groups, 100 patients that had a negative DAT but a positive antibody screen indicating an allo antibody, and then another 100 patients who were also anemic but had a negative DAT and a negative antibody screen, so really nothing coming up on serologic investigations. And 2 things we want to look at here is the hemoglobin response and the hemolytic response, and just draw your attention to the bottom of this table where they looked at the hemoglobin change adjusted for the patient body weights. When they looked at the mils for every 10 mils of RBCs per kilogram that were transfused, they found that there really wasn't a difference on day 1 after transfusion between the 3 groups. Group 1 here is the autoimmune hemolytic anemia group. Group 2 is the patients with a negative DAT but a positive Aloe antibody. And group 3 are the patients with a negative DAT and a negative Aloe antibody screen. And so on, by day 1, there really weren't any significant differences between the autoimmune hemolytic anemia group and the other 2 groups. So slightly lower response in the negative DAT negative screen group compared with the negative DAT positive Aloe antibody screen group, interestingly. But about a 13 gram per liter increase in the autoimmune hemolytic anemia group. And by day 7, the autoimmune hemolytic anemia group actually had a significantly higher change in hemoglobin, with about a 24.5 gram per liter increase compared to 17.5 gram per liter and 8 gram per liter in the other 2 groups. So some reassuring evidence that the transfusion therapy is actually effective at increasing hemoglobin in patients with autoimmune hemolytic anemia, especially compared with patients who are being transfused for other reasons. In terms of whether or not that worsens hemolysis, the LDH was followed to try and answer this question as well as the bilirubin. I picked the LDH just not to be overly repetitive with stuff, but the LDH, the bilirubin changes mirror what was seen with the LDH, which was basically nothing. So by day 1, there weren't really any significant differences in the increase in LDH that was seen between the autoimmune hemolytic anemia groups and the other 2 control groups. And by day 7, the LDH was similarly not different between the 3 groups. So for patients with autoimmune hemolytic anemia, I think this data provides some reassurance that transfusion support can be given safely and effectively. They interestingly looked at a couple other small comparisons they did in this study, which have to be interpreted, I think, with caution because of the issue of potentially of power in here. But when they looked at the patients who benefited the most from transfusions, it actually was the patients who were the most anemic, so patients who had the most severe anemia of less than 50. By day 7 had the best response in their hemoglobin with an average of 24.5 versus 17.5 and 8 in the groups that were slightly less anemic. And interestingly, the DAT strength really had no clear association with the response to transfusion, although there was a trend for patients with the more severe, I guess we could say severely positive DATs, the stronger strength on the DAT that actually had a better hemoglobin response by day 7. So really no significant difference between the groups, depending on the IgG strength, whether it was negative trace or 1 through 4 plus on day 1, but a bit of a trend towards a better response for the stronger DATs by day 7 with the higher DAT strength. And that's the IgG, and similar kind of story, although less of a signal of any kind of difference between groups when you looked at the C3d strength. So there really wasn't any significant difference between patients on day 1 or day 7 in terms of the hemoglobin change based on what the C3d strength was. So where does this leave us? I guess when we ask the question of when should we transfuse patients with autoimmune hemolytic anemia, I think ultimately the decision still becomes kind of one that should be individualized for the patient with factors that should be taken into account or might suggest to be taken into account based on symptoms, patient symptoms of anemia or signs of inadequate oxygen delivery. And some of the biomarkers that might be helpful in guiding that decision would be the troponin or a lactate level. Obviously, you wouldn't necessarily want to wait until those markers are positive, but if they are positive, you would certainly kind of have a much lower threshold to be starting transfusion support. Consideration of the patient's comorbidities is also quite important. So just in the second part there, you have consider a 50-year-old man with a hemoglobin of 85 who's got known coronary artery disease and symptoms of angina, and a 75-year-old man with a hemoglobin of 55 and who's completely asymptomatic. Well, that coronary artery disease is going to be an important comorbidity that's going to change how transfusion therapy is going to be decided upon for those 2 patients. And similarly, other comorbidities might be taken into account. The availability of the RBCs that are on hand. So again, depending on the particular center's selection process, whether they're using autologous, if that's feasible, or allogeneic absorptions, or if they're doing a phenotype matching strategy, particularly with the phenotype matching, you may have a situation where there just aren't a lot of options for transfusion. You just don't have a lot of units that are going to be little E negative or matching that full phenotype. And so the decision about when you transfuse might be kind of having to take into consideration keeping a bit of a supply for the more urgent indication if things change with that patient. So someone who's relatively symptomatic with a hemoglobin of 60, and you only have 2 or 3 units on hand and nothing more that's in sight for the next little while, well, you might want to keep those on hand in case things change. And then the severity of the hemolysis, something that's a bit of a double-edged sword. On the one hand, the patients with the more severe hemolysis, there's a concern that their hemoglobin could be falling more precipitously and may require additional transfusion support. But at the same time, if the transfusions aren't really being all that effective, the severity of hemolysis, could be such that the transfused RBCs are getting lysed right away. And for those patients, it may not make much sense to actually continue dumping in red cells if you're not really seeing much of an improvement in the hemoglobin. So I think the response to transfusion really needs to be monitored appropriately and should guide therapy. There really isn't a very one-size-fits-all approach that would work for patients with autoimmune hemolytic anemia, and should really be kind of tailored to the individual patient.
Excuse me, Dr. Mack?
Yeah.
You have about five minutes left.
Perfect. That should be okay. So just to briefly touch on the alternatives to transfusion, and I'd say here just as a starting point, I think 5 minutes is enough because there really isn't a lot of data on sort of alternatives to transfusion in patients with autoimmune hemolytic anemia. The alternatives are meant to that I want to discuss are kind of meant to be really specifically for transfusion options and not alternatives, meaning concomitant therapies. And obviously immunosuppression is a very important piece of the management of these patients. And another important kind of message I think to say is that the transfusions really should not be discouraged because of incompatible cross-matching. So although alternatives are important to consider, I think transfusion therapy remains a cornerstone of the support and management of patients with autoimmune hemolytic anemia. So for the basics of alternatives to transfusion, I think there's a few very fundamental things that often might get overlooked, and this is kind of just returning to basic physiology of why we would be transfusing and what the goal is of that. And again, if we're remembering this DO2 VO2 curve, the goal is to really increase oxygen delivery and decrease oxygen consumption. And when we look at the equations that predict or can calculate DO2 and VO2, there's a couple things that jump out that can be optimized. And so one of those I've shown here in red in the DO2 formula is the oxygen saturation. So if we're able to optimize how much oxygen saturation there is, then we're going to be optimizing how much oxygen delivery there is. And something that's not shown in this formula here is actually the dissolved oxygen content. So it's not all carried by hemoglobin. There's a small proportion of oxygen that's carried actually just dissolved in the blood. So putting people on supplemental oxygen can really sort of maximize that and maximize both their oxygen saturation and the amount of dissolved O2. Gains are probably minimal. There really isn't kind of a lot of science to estimate how much of an impact it is. But in someone who's otherwise quite unwell, I think something to consider. And then if their oxygen consumption is high, if they're having a fever, or if they're being quite active, decreasing that oxygen consumption by encouraging bed rest, treating the fever, can also help to sort of shift that balance between the supply and demand that's going on. In terms of specific therapies, there's not a lot that's been evaluated. Erythropoietin is something that's been looked at in there's a letter to the editor that was recently published where they evaluated 51 patients with autoimmune hemolytic anemia treated with EPO. This came from 9 centers across Europe, and the patients were, for the most part, pre-treated with at least one other therapy and had not responded to concomitant therapy. And the EPO was started really kind of fairly late in their diagnosis as kind of supportive care. So this is really sort of different from the acute setting where patients might be coming in with their autoimmune hemolytic anemia crisis at the outset. An interesting thing they found was that the EPO levels were a lot lower in patients with autoimmune hemolytic anemia compared with other types of anemia. So as you see on the graph here, showing that compared with patients with aplastic anemia and other causes of anemia where they included iron deficiency or B12 deficiency, that for any given level of hemoglobin, the erythropoietin level tended to be quite a bit lower in the autoimmune hemolytic anemia group, suggesting which is kind of the rationale for why EPO might work. And they found in these patients that within about 15 days of the initiation of EPO, they did see a good response, which they defined as a 20 gram per liter increase in hemoglobin. That was their definition of a partial response. And that persisted out for several months as patients were continued on. A little difficult to know in this study because patients were being concomitantly treated with other therapies. How much of this was the EPO and how much of this was some of the other therapies that were being given. But certainly some interesting data suggests that EPO might be a way of reducing transfusion needs in some of these patients. And finally, something that had a lot of attention several years ago and that may be on the horizon at some point in the future is the hemoglobin-based oxygen carriers, also known as HBOCs. There really isn't a lot of data around their use in autoimmune leukemia specifically, but something that if the safety of these oxygen-based carriers can be improved, may be something that becomes feasible down the road. So just to quickly return to our case, I'll show you here quickly is a graph of his hemoglobin over time. And the first phase of his admission, shown in red there, was where we were giving daily transfusions to support the hemoglobin. So he's getting on average 1 to 2 units a day without really much of a change in his hemoglobin. So by the 25th of March, we decided to back off a little bit on the transfusion support. He wasn't having a lot of symptoms of anemia, and steroids had been started along that time. We weren't seeing much of a response, so rituximab was added, shown by the blue arrow. And after deciding just to sort of back off and be a bit more conservative with the transfusion support, we still needed a couple days of transfusion, shown by the red arrows, but not nearly as much as we were giving for the first part. And he actually did quite well, and not shown on the graph here, but a few days later, his hemoglobin started to rise spontaneously, probably in response to rituximab, and he was able to be safely discharged from hospital with a hemoglobin over 70. So just to summarize quickly, I think important points to say that there's limited data really to suggest that indications for transfusion in autoimmune leukemia should be different from other patient populations, and the decision to transfuse should be individualized, taking into account some of the factors we talked about from the safety point of view and the patient symptom point of view. The response to transfusion should be monitored and over-transfusion avoided for patients who are tolerating the anemia. Concerns around transfusing incompatible blood should be tempered with the strategies that are used to mitigate hemolysis from allo antibodies like phenotype matching or auto or autologous or allogeneic adsorptions. And there really is limited data supporting alternatives to transfusion support at present, and I would view transfusion support really as a cornerstone for support in patients with autoimmune hemolytic anemia. So with that, I will end my talk, and thank you for your attention, and turn it over to Wendy and Wasim.
I think Dr. Anani, are you?
Yep,
I'm
here. So we're going to move to our panel discussion, and we'll go until about 3:55, and we'll give ourselves 5 minutes for the wrap up. So we have about 25 minutes between now and then. So thank you to all of our speakers. We'll now move to the open panel discussion. Our speakers are available to answer your questions. We're going to begin by reading out the submitted questions that were put into the chat function or any questions that were emailed to us. You can continue to submit your questions as we go through this part of the program. Just let us know which speaker you're referencing, because sometimes it can be a little confusing as the messages come through rapid fire. So I will let them start reading the questions.
Okay, thanks. Dr. Anani, I'm going to start off with a question that was posed to Dr. Pendergrass. And the question was, when will voxelotar, I'm not sure if I'm pronouncing that correctly, or oxbrita be available in Canada? And would that change the transfusion practice to keep hemoglobin S dilute?
Oh, that's a very interesting question. Oh, sorry, one second here. Get on mute. So voxelotar is one of the more recently introduced drugs to treat sickle cell disease. If people are not familiar with its mechanism of action, it essentially forces the hemoglobin molecule to stay in its relaxed configuration as if it were always oxygenated. And that basically hides a little hydrophobic domain that causes the hemoglobin molecule to come out of solution and into crystallize. It's been shown to actually increase hemoglobin by decreasing hemolysis, and this is certainly an important surrogate marker, and that in and of itself, will decrease transfusions. I think the question that has not been completely answered is what the clinical benefit to the patient is in having a hemoglobin molecule which is sort of forced into its oxygenated conformation, even when oxygen is not on it. And I think that is sort of one reason there's been a little bit of hesitation about sort of rushing out to start using this medication, even in the United States where it's approved. It will probably be approved at some point in Canada as well, but I think a lot of clinicians who are looking at this really want to see some, some actual better clinical endpoints to show that it actually improves patient symptoms and signs of disease, rather than just sort of driving the hemoglobin up. But it's definitely a very exciting new therapeutic. It's just the whole concept of basically hiding the little hydrophobic domain as a therapeutic strategy is very cool. I think we just want to make sure that that actually is being good for patients.
Okay, thank you. Then next we have a question for Melanie, actually, and it was a question about the auto control being negative after the Aloe and auto adsorption.
So typically we do see that the auto control is negative, especially in patients that have not been transfused. So we got rid of the interfering autoantibody that is pan-reactive with everything. So that's one of the reasons why the auto control would be negative. Only if a patient was recently transfused with also having an antibody. So say the patient was transfused last week and developed an anti-JKA, and we gave him JKA positive red cells. After the adsorption, then the auto control might still be positive because the Aloe anti-JKA will react with not his autologous cells, but with his transfused red cells. So it's not uncommon for an auto control to be negative after absorption.
Thank you. Now we have a question for Yulia, and actually I asked this question this morning. I'll just ask it again because we don't have any entered in the panel. The question was about outpatient clinics and the push to move patients through fairly efficiently, just because those chairs are so valuable, and if there's any increased risk or increased concern about outpatient transfusions in that setting where the patients are being kind of pushed through quickly.
Yeah, so that's a great question, and I think for sure for any of us who are involved in outpatient clinics, there's always that pressure of just a limited resource in terms of having enough chair time and enough appointments to be able to accommodate all patients who need transfusions or other activities that might be happening within the transfusion clinic. So, I think the way we've managed this here is, on one hand, if you look at MDS patients, they tend to be older. The median age was 70. They tend to have many comorbidities, so may have risk factors for example, circulatory overload, including heart failure, kidney disease, age. So they already have those types of risk factors, so are at increased risk. On the other hand, compared to inpatients, they may not have their sort of active inpatient issues, whether they've just been, a positive fluid balance from getting resuscitated, or have, inflammatory components that might also lead to, perhaps contributing to circulatory overload. So I think definitely there's a risk of TACO in these patients with MDS. The way we've managed it here is we do have built-in pre-transfusion diuretics on our order sets, and so we think very often about treating any patient who is at risk, typically age over 60, who requires a transfusion with pre-transfusion diuretics, and that's how we try to mitigate that within the transfusion clinic.
Okay, thank you. And the next, we have another question for Dr. Pendergrass. So does it mean that any sickle cell patient who is ventilated for COVID pneumonia should be exchanged? And also, in addition, assume they have acute chest, since that checks off all the boxes on your list?
Wow, yeah, that is a really good question. Not a lot of evidence yet on that question, as you can imagine, but that is a scenario that I think a few of us who treat sickle cell patients have encountered already. All I can do is give you my own personal view on this, which is I tend to intervene fairly early in sickle patients who are developing COVID pneumonia. We do know, pretty good evidence based on case control studies that outcomes are much worse with sickle cell patients than other patients. There was one study that was recently presented that suggested that the mortality rate is actually 6 times higher than age and ethnically matched controls in patients with sickle cell disease who develop COVID pneumonia or COVID infection generally. We know that this is also true for other respiratory viruses like influenza. So if I would a patient who is admitted with COVID pneumonia, I would probably be opting for an exchange transfusion right up front, unless they were very, very, very mild and it was sort of one of these kind of, is it or is it not kind of chest X-ray reads, in which case I might try a top-up transfusion. But I would tend to treat these patients fairly aggressively. I will say that the data that suggested that this much higher mortality rate was that was sort of a health systems database inquiry, and included large numbers of patients. Before that study came out, there were small case series of patients presenting in the United Kingdom with sickle cell disease who developed COVID-19 infection, and their outcomes were actually not that bad. And I think one of the things that came out of that was that a lot of those patients were already on some sort of chronic disease-modifying therapy. Many of them were actually chronically transfused, and the thought was maybe that was protecting them from a worse outcome. So again, the data is very, very new on this, but I would lean towards aggressively treating these patients. And yes, I would be doing an exchange transfusion if they had certainly any of those indicators I said in my slide about worse outcomes. But yeah, I would tend towards more aggressive therapy, but that's just me.
Okay, thank you. Melanie actually posed a question in the chat function, and she said it's standard now for issuing blood that's RH and Cal similar for sickle cell patients. Will it be the same for MDS patients soon? And I don't know, Melanie, if you meant to ask, poll the audience to see what other hospitals are doing as far as that practice, or?
Yeah, or even polling the audience would be great too. Because that's something we do not do here at the Ottawa Hospital.
Okay. Yeah, I know. I think I asked that to Tracy just as an aside, so I'm not sure if she was able to set up a poll for that or not. But we can see if she
have it. I can pull it up.
Okay.
Hold on a minute.
It's okay. And then I think Tracy, you have some other questions.
We can always ask Yulia. She's our resident MDS expert.
Yeah, I think we put a question together for the poll. Is that right, Tracy?
We did.
So I'd be interested to see what, are we able to run that poll right now?
Yeah, I'm just trying to pull it up. I had it hidden because I was afraid we didn't have enough time, so just bear with me.
Yeah, this morning with her. So maybe, can we go to you, Dr. Anani? Did you have any questions that you had on your
questions. That's the problem. Sure. So this is, I guess, more of a question for the sickle cell folks. So if we're talking about a hemoglobin parameter as being important in terms of dropping that threshold lower for sickle cell patients, would you recommend your techs actively look at the hemoglobin when an order is being placed, or just focus on getting the matched unit out the door? I'm curious how you guys approach it at your hospitals.
Yeah, another really, really good question. In fact, at the University Health Network, our blood bank will not issue blood to a patient with sickle cell disease for any indication unless it was ordered by a hematologist, because there's so much more involved in this than simply looking at the hemoglobin. And we also know that these patients tend to be transfused fairly liberally. In fact, even a patient whose hemoglobin is less than 50, there may be a very strong reason not to transfuse that patient, like if they had a history of hyperhemolysis, for example. So our blood bank staff will confirm that the order was okayed by a consulting hematologist. And if not, then they escalate that to medical director. Now, that's a standard of care that maybe is not possible to be met at a smaller hospital that doesn't have any hematologists on staff. I would still propose that even at a smaller hospital, you should probably be getting some sort of consulting hematologist on the phone before you issue blood to a patient with sickle cell disease. Now that may be something that would be suggested to the ordering physician so that they could then reach out to find a hematologist to speak with. But in fact, at our clinic, we actually issue cards to all of our patients where we essentially say, don't let anyone transfuse you without checking with us first. If you go to a different hospital, it's such a different set of rules for these patients, and the harms that can result are so significant that it really, to my mind, needs a specialist consultation, unless it's an absolutely life-threatening emergency, like a patient is bleeding to death, for example. But again, it's easy to say that if you're working in a hospital where there's an on-call hematologist all the time. I understand it's difficult at a smaller center.
All right, so now we have the question up. Please text ORBCoN CBS 685 to 37607, and then once you join, you can enter your response. And the question is there. You just have to make it. Can someone make that? There we go. Thank you. And then while we're waiting for people to respond, Yulia, for your MDS patients, since they're also getting TXA, would you ever foresee if TXA is becoming used more commonly that you could potentially push your hemoglobin threshold a little bit higher since they're not having as many microbleeds?
Or you mean push the hemoglobin a little bit lower? Or
yeah,
like
sorry, I did it backwards.
Yeah. No, I think, yeah, it's interesting. I think that, I think there was just a recent publication that came out actually that looked at higher and lower hemoglobins and did not actually show a difference in terms of bleeding. So even though there's been sort of that theory that, higher versus lower hemoglobins might predispose to, better hemostasis, I don't know that that's actually been shown to be true. And there was a recent study that came across, I think, that I've seen that did not support that theory. So I actually, I don't think it should change too much. Again, probably, these are patient-centered discussions that need to look at kind of the symptomatic improvement if there is with transfusion. And if there isn't, then I think choosing a very restrictive transfusion threshold is probably the way to go. Now, having said that, there are many patients who do state that they have quite a benefit with transfusion, and so are transfused at sort of higher thresholds in terms of their daily function. So I do think it's an area that really deserves a lot more attention and research as we move forward.
It looks like it's about 3/4 do not have a guideline for their outpatients versus 25% that do have a guideline for their outpatients. If anyone does have a guideline, if you could type it into the chat function, that would be helpful so that Tracy or Wendy could read it out to us.
And I think, Tracy, the next question has to do specifically with the PAM or prophylactic antigen matching.
Oh, okay. Yeah, so just hold on. See.
Oh, yes, that's the one we were looking for.
Let me activate it.
Activate that for us, thank you. And I'll ask a question while we're waiting then. And this is for, I don't know who this will go to, whomever. So back in the US, when we had pediatric sickle cell patients, we would sometimes specifically choose units that did or did not have the adsol just to mess with the hemoglobin or the hematocrit concentration when we were doing exchanges. Is that something anyone should consider for a smaller patient that it has sickle cell disease?
Yeah, it's not something that that I typically worry about in terms of the effect of the red cell additive solutions. You know, there is a consideration if you are doing a large volume apheresis exchange. Like if you're trying to, do a 1.5 times blood volume exchange for, as like an acute intervention for a patient, say who's having an acute ischemic stroke. That's a lot of optimal additive solution. It will certainly make the exchange take longer. It also, may render the patients, transiently coagulopathic. So I think, there's sort of maybe that consideration if you're doing a very large exchange. But it's actually not something that I think is standardized. Certainly we don't do this for adults unless they are having a history of frequent transfusion reactions that we think can be mitigated by removal of the small amount of plasma that's still present in the unit of red cells. But I don't typically worry about the toxicity per se of the optimal additive solution itself. I mean, certainly, any exchange patient, you have to keep in mind, the risk of citrate toxicity, but most protocols can account for that as it is.
And I'm not sure who's driving. Could someone just scroll down for us? Because it looks like we have a couple of yeses, but so far mostly no's. So 2 yeses.
And I'll admit that one of those is from me, from Sunnybrook.
Okay.
It's an interesting question. I think as we move forward towards sort of more personalized medicine, I don't know that this is specific to MDS patients, but I think it's just something that we should think a little bit about. Like I know for us, our policies include prophylactic antigen matching for patients who are getting chronically transfused, whether it's MDS, myelofibrosis, autoimmune hemolytic anemia. We've even just recently added hereditary hemorrhagic telangiectasia because they also seem to develop antibodies. And much of that may just be the burden of transfusion that they receive. But I think over time, that would be a direction in which I think we should move. I think that, of course, that needs to be balanced with what resources are available. It does cost money to type patients. And we also need to be aware that we also don't want to be taking away resources from patients who probably do need it a bit more in terms of like sickle cell patients or patients with hemoglobinopathies. So I think there's definitely a lot of things that go into making that decision. Our center doesn't have a large group of hemoglobinopathies. Those are all mostly at UHN and at sort of our outer GTA hospitals. So we have, that luxury to be able to divert some of our resources towards other chronically transfused patients.
And while we're waiting for this one to fill out, one final question really for all the speakers. Yesterday we did a wet workshop, and one of the techs out in the Ottawa area actually asked an interesting question, and I know how I would answer, but I think it may vary depending on where you are. There was a case where we gave them an anti-M that only reacted at immediate spin, an FYA and a big K, Aloe antibody, and the question was if there was, and this was a supposed sickle cell patient, and the question was if this was only an anti-M reacting at immediate spin, and your current policy was only to match for RH and the KEL blood group system, would you extend the match since they've already made a clinically insignificant antibody at immediate spin? And really this could be applied to your MDS patient, sickle cell, and warm auto. So if any of you have just something brief to say about that, whether you would extend the match or leave it as is.
Yes, Jacob, I'll jump in and say I would, but I can understand the controversy here. But my rationale is that what you are trying to identify here are patients who have a proclivity to make antibodies. And that proclivity may not have anything to do with the particular antigen that they respond to. It may have to do with their own HLA phenotype. It may have to do with, you know, the inflammatory milieu in which the transfusion was administered. It may have to do with their Duffy status. There's a million theories about this, but regardless, if they've made an anti-M, to my mind, that means they can make it another antibody, and I would therefore extend the match for those patients as well, to include all the other things, so, you know, the Duffys and Kids and S's and that kind of thing. Also, and again, this is something we do see occasionally. You know, some of these, you know, quote unquote benign, close quotes, glycophorin targeting antibodies are potent activators of complement, and we have seen some nasty cases, N's mostly, but even M's. So, you know, we may be, you know, it may be necessary to do some of those additional steps to really determine, you know, what its phase of reactivity is. You know, like checking to see for sure that it's IgG phase, for example, or that it reacts to 37.
Yeah, I'll just comment from Sunnybrook. I was just looking at our policy to see if we had anything in that, and I think if we had an anti-M that was immediate spin, we might not necessarily do extended matching in that case. One thing that we have introduced over the years is that even if a patient does not have an antibody, we are doing IAT cross-matching, and I think that's something that we've sort of taken over and followed UHN's lead. So even in patients who have a negative antibody screen, and it's always been negative, we are doing a full IAT cross-match for those patients. And that's really to, you know, for low frequency antigens or whatever might show up.
And Dr. Mack, if you have a quick comment before we wrap up.
Yeah, I would just add, I think locally we wouldn't sort of for all patients necessarily extend the matching in that kind of a situation. I think I think I would have a bit of caution in a patient with an background of sickle cell disease, like you had mentioned, that as Dr. Pendergrass mentioned, that's sort of a sign that that's an antibody maker, and you'd be more concerned about than potentially other antibodies, and then the concern about hyperhemolysis down the road from a delayed hemolytic reaction. In other patient groups, I may not be quite as concerned, so would take those factors into account.
Perfect, thank you. So it looked like we had 22% that matched for RH and Kel phenotypes. So now we're gonna wrap up our session. So thank you all, once again, a reminder to record your attendance to this event by either signing the attendance sheet or logging into the webcast. Please provide us with any feedback you have on today's event. Not only is it important to comply with requirements for CME accreditation, the evaluation helps the planning group organize an event that will provide the audience with information they're looking for. Each year's event is planned using suggestions we receive on the evaluation survey from the previous year to ensure we incorporate speakers and topics that you want to hear about. The link to the evaluation has been made available in the chat function, and we'll also be sending you the link to the survey via email following the end of this event. On behalf of the organizing committee, sincere thanks goes to the organizations that provide us with funding to hold this event, Canadian Blood Services and the Ontario Ministry of Health. Many thanks to this group of dedicated individuals who've been meeting for the past 6 months to make this event possible despite the challenges thrown at all of us from COVID-19. And the presentations are posted on the website on the event page for this event. Just click on the events, upcoming events, and the title of the event. Then select more, and it'll bring you to this page. And if you have any ideas for what you'd like us to present at next year's event, please make sure you drop us a line through the evaluation survey or email directly to Tracy Cameron. We take them very seriously, and as I said before, many of our events are shaped around the recommendations made by those watching. And then with 2 minutes left to spare, we are now officially done, and we hope you have a great rest of your week.
Thanks, everyone. Thanks to our speakers. Great presentation.
Bye, everybody.
Bye-bye.